About mini PCNL with section. Гохуазен, China.
What?
Да, включите, пожалуйста, видео онлайн. Онлайн видео, пожалуйста. Технический персонал. Можете включить. Гохуазен, China.
Dear friends, dear colleagues, ladies and gentlemen, good morning. I'm Guo Huazheng from Guangzhou Medical University, Guangzhou, China. I will talk about mini PCN with suction. Before my presentation, I will talk about definition of mini PCN. According to IU Global Exports consensus, so standard PCN axis size is more than 24 French, and the mini PCN axis size is less than 18 French. And too many urologists like to do standard PCN and don't like to do mini PCN. Why? Because compared to standard PCN, mini PCN has two main problems. It's longer operating time and a higher pressure and more infection complications. Every guys come back to the real world. You see, from 1998 to 2023, in the past 25 years old, our department have finished more than 40,000 PCN procedures. You see, mini PCN is up to 40,400, and the standard PCS is released is only 2,700. Actually, for this 40,000 mini PCN, you see this is stone size is average stone size is 3.7 centimeters, and the Steghorn narrow stone up to 33%, and the initial stone flare is almost to 18%, and all over stone flare is almost to 94%. But this is not high quality evidence publication, and in 2020, our team finished this RCT, compare standard PCN and the mini PCN for 2 or 4 centimeters little stones, and this is from 20 Charles centers, and the preliminary endpoint is 1 session stone flare. From this publication, you see, compared to standard PCN, mini PCN has many advantages. It's similar stone flare and reduced blood loss and less post-operative pain and shorter hospital stay, but mini PCN does not increase the infectious complications. And sometimes mini PCN has a long operating time. For example, this stone size more than 5 centimeters real stone maybe take a long time compared to this standard PCN. How to shorten the operating time for mini PCN procedures? Maybe you can use suction mini PCN SMP system. The first I talk about history of suction mini PCN. In 2000, I started to do traditional mini PCN. I always think it, how to shorten operating time during the traditional mini PCN. Maybe suction is maybe it's good way. In 2007, I started to make design, and in 2009, I gained the Chinese patent. You see this figure, and after 9 years, I developed this suction mini PCN system, and 1, 2, 3, 1 conception, 2 types, and 3 parts. I can talk about for more detail one by one. One conception is suction. With this suction system, you can lower pressure and you can effectively remove stone fragment very fast. It's suction out. No need the forceps and the basket. Remove stone fragment one by one. Another two types, SMP and the ESMP. And there are some different between SMP and the ESMP. SMP is exercise is 14 French and the ESMP is 18 French. And the suction shears for SMP is double layers and the ESMP single layers. And the leftoscope size, SMP is 18 French and the ESMP is 12 French. And for SMP leftoscope, working channel is 3.3 French. And the ESMP leftoscope is working channel is 6 French. And for SMP, lethal trips only for laser. And for ESMP, you can use laser lethal chips. You can use numerical lethal chips. And the indication mode for SMP is from sheath. For ESMP is from leftoscope. And the indication SMP is the basic indication is less than 2.5 centimeters, and the ESMP is more than 2.5 centimeters. I show this video. This is SMP. You see irrigation from the sheath and the suction stone out. And this is ESMP. Irrigation is from scope. Because this scope working channel is 6 French, irrigation is enough. Everybody must know for suction millipercent, irrigation is really important. Low irrigation, no water, no function. And the other is 3 parts. The first is suction shears. I think the suction shears is very important. And this is shears and the suction port, different size. 14 French is for SMP and the 18 French for ESMP, and the different lengths usually use 14 French centimeters. Sometimes for very fat, with an opposite patient, you can use 16 centimeters. 2 types. Is single use is from plastic. This reusable shears is from metal. Actually, I like reusable because this is economic. You can use many times, more than 100 times. And another is mini leftoscope. And at first is scope is fiber. And then now it's changed to rigid leftoscope. Is because this rigid leftoscope is low camera, is very light. Endoscopy view is very clear. I like it. Use this scope. And the irrigation suction pump is very important in both SMP and the ESP system because suction is very important. This suction not enough, and this is because its irrigation is not fluff, and the suction is ineffective. And actually, suction pressure and the mass less irrigation pressure about 5 or 10 millimeter mercury. Actually, CAEC company has developed pressure monitor leftoscope is on the Chinese market. It's very suitable for infection stone PCNL. Actually, this RCT is ongoing. This compare pressure monitor scope and the traditional leftoscope SMP is okay and not okay because with this pressure monitor leftoscope can lower infection complications a lot. This is really important. And then and actually our team have finished compare ESMP traditional millipercent without suction shears. You see this is a single central RCT, and the stone size is more than 3 centimeters. And compared to traditional millipercent, suction ESMP has a shorter operator time and a higher stone removal efficiency. and the lower pressure and less post-operative favor. So for ESMP, basic indication is more than 3 centimeters renal stones. And actually, we have finished this ESMP to standard PCN for 2 or 4 centimeters of renal stones, and the ESMP is 2 balls, 2 arms. Its cases up to 480 cases, stone size 2 or 4 centimeters. You see, initial outcome is okay, it's better. Similar operative time, and the one stage stone flow is the same in 2 groups, but in ESMP arms, and has less bleeding and less pain and less complication and shorten hospital stay. Which case is more suitable for suction mini PCI SMP? I think all cases are suitable for SMP, but this case is more suitable sometimes for calyx infundibulum is really little and long, and the cases with high risk of bleeding, such as solitary kidney, and very, very complex cases required multiple punctures, and the patient with very, very complex renal anatomy and the pediatric renal stone, maybe you can do ESMP better. For example, this is solitary kidney. You see this is stone size 5.5 centimeters, and you see this is infundibulum is very little and long. I make a puncture from middle, and one puncture remove all stone. You see, it's no use flexible laparoscope, no combined approach. And the left tumor is removed post-operative 1 day, and the heavy jawbone is released and no complications. Discharged is post-operative 1 day. You see stone flake, and another is a pediatric little stone, and the boy is 11 years old, and the bilateral Stegenham little stone. You see this SMP for right little stone. After operation stone already size, little size is 16 stone. This is pre-operative KUB and the CT scan. And I make a puncture from Piacho Sun guidance. You see this, I think this is a middle calyx posterior, middle calyx Piacho Sun guiding puncture here. Maybe you can see, I get this stone, and then I must confirm this stone is okay, tucked is okay. You see, under X-ray is posterior, middle posterior, and the front middle posterior ESMP, and then lower stone. This stone is left. Of course, you can do flexible, you can do shockwave. But for me, I make a lot of puncture, remove stone, 2 punctures, and the tubulus, and the patient is stay surgery, stay hospital 1 night, and you see it's low complications. Another is SMP for infection stone, because infection stone, you must remove all stone, otherwise maybe recurrence is really easily. This female, you see is 2 infection stone, multiple stone in 2 kidneys, and you see I will do left side first. I see make a puncture, many puncture, 1, 2, 3, or 4 punctures, and the tubulus and the stone flake. I think this is post-operative CT scan. I can show you. Okay. Actually, a larger question is how to reduce the numbers of axes in suction mini PCN. I think it's good puncture. What means good puncture? It means you use minimal punctures, remove maximal stones. This is good puncture. And then it's needle assistant puncture and the stone relocation. And the PCN combined flexible, this is okay. And the integrate flexible is okay. And the fence mini PCN, this is is a new technique. I show this for you. Actually, this is liminal. This is similar to fence sheath, and this flexible left scope is 11.4. You see French, and the working channel is 6 French, and then is with 18 French percutaneous fence sheath, and you see this really nice. Okay, this is 18 French sheath, and the bendable part is 18 centimeters, and the working length is 12 centimeters, and you see this is remove this handle, and then you can connect this aspiration machine, and this is from flexible. You can like a fence, it's the same, and then you can with the sheath go in, and then you can with the sheath together. Then you can with the sheath go in and suck stone out. Use this case is a branch, a collecting system, a puncture lopo, and remove the stone. You see as this stone is here. I use this fence midi poke and remove the stone. This small stone left, I make a larger puncture and inject water and push stone to the pelvis and remove again. Then stone flare. And show you this fence midi poke technique. You see, you laser break stone and suck stone very fast, maybe. Sometimes you use flexible left scope, use basket remove stone is one by one, very slow. And with suction sheath is very fast. You can suction stone very fast, you see. And the other one is fence midi poke. Actually, for example, maybe you can solve those problems, slow stone removal in traditional flexible laparoscopy, and avoid the multiple puncture, and particularly suitable for high bleeding risk patients, and includes one session stone flare. Summary: for SMP, 14 French sheath is being published partially replaced by fence, but it remains suitable for pediatric stones, and for this SMP, no need to place stenting, no need the multiple accession initial session. And for ESMP, 18 French sheath is suitable for more than 3 centimeters real stones. Compared to traditional mini PCN, it is shorten operating time and improve stone flare. And come to standard PCM, it has a similar stone flare, less bleeding, and a faster recovery. And the fence midi poke provides a new approach for treatment of very complex calculi. Sometimes this patient need multiple punctures. Actually, in the future, nano robotic combined AI maybe is a good future. For this nano robotic injected in the bladder, and then this machine can automatically identify the orifice of urethra and go in the urethra and go into collecting system. And you see this robot, he can automatically identify which is normal mucosa, which is tumor, and which is stone. You can find the stone, and then you can bite stone, and then you can bite stone and make a stone is starting, and then it's okay. And then you can see, you cannot go to hospital. You can stay at your home and watch this robot.
Hello. 辅助一下后面那个。OK。
Actually, I think future is nano-robotic. We combine the AI. So this nano-robotic can automatically identify the orifice of urethra, and they go into urethra and they go into collective system. And this robotic can automatically identify normal mucosa, which is tumor, which is stone. You see, he find the stone, and then he patch stone
можете
and
остановить
they
уже, да?
make stone into dusting. And then you don't
Пожалуйста,
go
вот
to
технический персонал,
hospital.
можете
You can
остановить? Все, thank you. Live surgery. Азимжан, нужно включить live surgery. Профессор Питер Алкин просит, если можно, и можно на русском задавать вопрос, на узбекском, на кыргызском тоже. То есть не стесняйтесь. Да, можно.
Professor, dear Professor, are you hearing us?
Все, стоп, no question. Это live surgery, пожалуйста, включите, соедините. Если не готовы, профессор Петр Алкин готов начать презентацию. Готово, да? Не, no, please wait. Измежон, что там?
Hello, can you hear us? Hello?
Mas?
Hello, can you hear me?
Yes.
Yeah. Hello, so good afternoon. I'm here together with Dr. Dilmerud and a great team, and I'm not sure if someone presented the case already.
No.
Yeah, it was presented? No?
First is the
Just
presentation.
very short. That's very short. We'd like to see you.
Okay, just to explain to you again, I think you have the image here. So what we have is a quite obese female patient with a Stackhorn stone, and what we expected from the CT scan was a renal pelvis lower pole Stackhorn stone, but after imaging today, we realized with the retrograde image that it was a Stackhorn stone that obstructs the full upper pole of the kidney. So that looked a bit weird, and we decided, since this was the standard here anyway, and it was a case that was not completely clear to us, to put the patient in a supine modified lithotomy position and to evaluate first from below by flexible scope. We just have to switch on everything because we waited quite long. And do you see the X-ray now?
Yes, we have it. Thomas,
see it?
just
Yeah.
go on. Go on, because
Yes.
they say you will do the case
Okay.
in 30 minutes.
Yeah, I think we waited now 1 hour, but now we start.
Yeah.
So what I show to you now is the fluoro image. If we have fluoro, I just have to go a bit backwards again. Fluoro, that's the lower pole where there was no stone. And in the upper pole, we have we need some more irrigation again. Kidney is empty after waiting for long. And what we did now was we did not an endoscopic guided, but endoscopy supported upper pole puncture. which was done by Dr. Dimroth. And you see here we have the wire inside. And our plan was now to start with a laser lithotripsy from below as soon as I have visualized the stone again. And when we have created some space, he will dilate to
So you
16
made,
French.
Thomas,
Yeah, Peter?
you try to create some space for the puncture?
Yes. The puncture is done already.
Ah,
And what you see in the X-ray is just have to get upwards again. That's a bit difficult always.
so you've done the
And
puncture.
we used yeah. It was an upper pole puncture by triangulation, fluoroscopy guided. So that is the lower pole. Have to go a bit backwards.
So I do
You
not
see, can we get flow
understand.
again? Fluoro, yeah. Right. Yeah, here's the stone.
Yes. Why don't you
And what I do
with,
now,
why don't you proceed with dilation?
that was Dr. Dimroth's preference. I mean, we could
Just explain that.
don't let you be pushed by Peter Alken. So do what you prefer.
Okay.
So
Okay, just
Yeah,
we
laser.
decided
yeah,
a little bit complicated.
yeah. He
case.
felt safer with the puncture if we create
Yes,
some
yes.
space, and that is what we do.
We already done the puncture for
Yeah.
the upper pole, but there is a little space. That's why we decided first to make some room using that's flexible, and to be sure that we're in the right place. And then we will make dilation and
So
go with the
With the
yes,
with the
medium.
trilogies then.
Yes.
Yeah. Which is a soft stone. It's almost radiolucent, and Hounsfield units were 500. So I need some more. Yeah, put the laser closer.
So what we will see next is lithotripsy through the ureteroscope. Huh?
Yeah, need some fluid again to get upwards.
Maybe we.
Just give me
we,
some.
Where's Azim?
Yeah.
It's closed here still. Yeah, correct. So I'm using a holmium laser, high power holmium laser, which has a fragmentation setting, because the aim here is, but you see how difficult it is to visualize the stone. A fragmentation setting, because it's not our aim to dust, but to create fragments quickly. Yeah, fluor again. I'm always one again. Yeah. You see, it's through this narrow neck. You really have to target it. And if I'm not doing well here,
Okay. Yeah.
maybe. So here we have the wire, by the way, visualized. So you see,
Yeah,
it's a perfect puncture. I mean, what Peter said is probably right, as always, that you could safely dilate here.
Okay, Thomas, it's Lorian here. We
Yeah.
will watch you lasering for a couple of moments, and then we will move to the next presentation while you continue lasering. At the moment when you guys are happy
Is the laser
to...
switched on though?
Can you hear me?
Yeah. Great. Yes, but
Thomas, can you hear me?
yeah, I can hear you.
So we will
So
watch
can
you
you switch
lasering
off
for a
the,
minute, then we
can you
will
switch off the pilot beam?
move to
Can
the
someone switch
lecture.
off the pilot?
Pilot. Off the pilot.
So what I personally prefer is to use
Okay. And then when you start dilating, please let us know. We will be in touch with you because we would like to have the dilatation.
so what we need
live.
is less ventilation. You see how this moves? Is there an anesthetist?
Anesthesiolog.
Yeah, we need a flight ventilation. Otherwise,
So
Sorry,
can we
cannot
go
manage.
to the next lecture now, please?
Pasaj tercebuladın da.
Yeah, next lecture is by
Can I press the
Legend
button?
of Urology, Same time,
So someone has switched off the laser?
Petralkin.
Sorry.
Vicinal
So-
complications.
We want to see surgery and not listen to lectures, so I'll try to run through it. This is dedicated to the young ones among you, and I want to share with you my conflict of interest initially. I present, you listen, however, at the same time, war crimes are being committed in many parts of the world. As urologists, our main interest and most important task is to improve patients' lives and prevent suffering. And so let's transform suffering into well-being, stand up for humanity against cruelties and crimes committed in the name of nations, religions, and money. So these are our genuine conflicts of interest that we have. Now, to the complications. Thank you for adding to my title, the master. This was not done by me. The question is, do they master, do the masters shape the future? I don't think so. Here we have an example. That was a good puncture with stone contact to a calyceal and pelvic stone. I inserted a guide wire which passed easily. I dilated to 20 French. No residual stone after disintegration, no nephrostomy. Unfortunately, this was just the second puncture, a few millimeters away from the first puncture. And the first puncture showed the collecting system and also the renal vein. So, if I would have not done dye injection after the puncture, I could have inserted my guide wire, which would pass freely into the renal vein. I could have dilated to 20 French, and then massive bleeding and nephrectomy. And my question to you, what is more interesting, to know the complication or to know what mistakes I have done? Definitely, complications are a lot, but we don't, as you will see soon, we don't hear a lot about complications, or about mistakes. Basically, there was a recent review on complications and percutaneous procedures. There are approximately 10% intraoperative and 20% postoperative complications. Ready for dilation, so we stop and we go and see surgery, more interesting.
Anora, please.
Thomas, can you hear us?
Anora, please, the voice from the OR.
Thomas. Hello. Hey, Thomas. Professor Knoll. What's going on? We want to see dilation.
Okay, we're on. So I'm now just doing the dilation success.
Yeah.
If you can see in our X-ray.
I think the scope broke.
Can you show the
Okay, you can
dilation?
change it, no problem. Just let me explain how we did in supine position. First of all, this line, you see, it's a posterior axillary line. Here is a rib line, and
So,
iliac line. So here is the safe area, and we puncture exactly to this place. Before we did already ultrasound check, there is no other adjacent organs. That's why it's a safe place. So we use that not rigid push, because this is an upper pole, a little bit difficult, no, but anyway, we're still in a calyx. Can you use a little bit contrast.
The scope is broken, but I can inject.
Yeah, just inject
Yeah.
and we can change. Let me-
You do a one-step
That's right.
dilation.
No.
Contrast.
Just we should put some contrast and show you where we are.
What kind of dilation will you do? One step?
Okay, good.
Not one step.
Balloon?
No. Not balloon. Not balloon. That's flexible. That's
Sure.
just
Is this contrast? No. It's water.
contrast one.
Really?
Little close here, yeah.
No, it's closed. It's completely closed.
And then I use metallic bush. I show you later.
Yeah, that's all I get in. Yeah.
Okay.
Okay. Good. Where's the wire?
We also use a metallic bush dilators. Elastic. Ага, инчкасынан бер, кейін рабочий бересің.
Okay.
It should be very gentle movement because we can bend this guide wire. So yeah, a little bit stuck. Yeah.
So this one is broken?
Yeah, you can take it as a new one. It's not
Yeah.
yeah, no, flexible. I'll teach.
Just put it down. Huh? Yeah.
Can we go back to the previous angle to see Dilmurad's hands, please?
Oh.
I can do it. You can focus here.
Oral. Ana gittiğim ki var mı paranı? Yok, ana paranı. Tamam. Tamam. Lastik. Lastik serum.
You tell us a little bit about what the problem is.
I think a little kinking here is. So I'm trying to pass this kinking, but it seems no kinking, but not going through this.
So you
Maybe.
I think this would be a good case to show.
Yeah, I pass it.
Coordination.
Yes, I passed this kinking, but I'm trying. We change it flexible. It was.
Hey,
The disposable was too disposable.
Yeah.
why don't you close the shutter a little bit? Collimation to have reduced radiation.
Just to put the contrast, I need some.
Yeah.
To be sure, I am in a inside of phallic system.
Just straighten it.
Watch it. Okay.
Is the wire still there? No,
Yeah. Yes.
not really. Huh?
Yeah. Right wire is inside.
So where you have to solve, perhaps?
Okay.
Okay. Just show where we are. Okay,
Okay.
good. Okay.
Can you show me?
Move the wire.
I'm in my bush.
Okay, good.
I think it's very close. Very close.
So you are asking for a
Yeah, yeah.
flow
You see it?
buttress? Should I go backwards?
Good.
Thomas, can you hear me? Thomas, can you hear me?
Дильмурат.
Oh, hello. Yeah, Nurbek. Yeah, I'm here.
Петр Алтын возмущается, почему вы не комментируете нам? Что случилось там? На русском объясни, говорит.
Ну, здесь немножко сейчас у нас поломался flexible. Мы его поменяли сейчас, чтобы on the guidelines of flexible we need that access. So
It's not so easy as it looks.
Take a new one.
You see, I'm here
Yeah.
close. Yeah.
do you see my
Give me some
bush?
indication.
No? I'm there, check.
Dilmurad and Thomas, can you hear me?
Yes?
So while you're doing this, can you
Диль-
explain
Доктор Дильмурат,
what your plan?
мы должны учиться...
Yeah,
Can you
именно
speak a
вот
little
эти-
louder? I can't hear you now.
Вот эти ошибки мы должны учиться. Если сломался, нужно нам комментировать, что сломался. Вот просит
Да, да.
наш
Ну,
учитель.
сломался, мы сейчас поменяли. Теперь, сейчас я проконтрастировал теперь. Хочу попасть уже, пробужировать и попасть в чаш-лахан систему. Но немножко имеется тоже кинкинг вот этого проводника.
So what he's doing now is he's using the single step dilator.
Yes. Now I'm using the single step. Anakan ringing
Yeah.
There's a little bit kinking, that's why I...
Can we please
Dr.
have the
Shashman.
view from the other camera, external camera?
Just show us ringing first.
The view from
One
the
step
other external
is
camera.
push. Ah.
Дильмурат, все просят комментировать. Все, что там происходит.
Сейчас, значит, пытаемся потихонечку бужировать. Почка очень мобильная, то есть толка, она просто отходит. И в этот момент происходит сгибание проводника. Поэтому миллиметр за миллиметром мы идем. Я не спешу. Камень у нас негативный, мягкий камень, поэтому, видите, на рентгене тоже плохо видно. Мы должны проконтрастировать. Little bit contrast.
Contrast.
Сейчас опять проконтрастирую, я посмотрю, я в пределах, то есть дошел до чашечки или нет. Окей. Очень близко мы, потому что камень тоже пристеночно, то есть очень мало мимо камня я прохожу, поэтому сейчас я не спешу. И чтобы как бы не продырявить чашечку.
Can we have the endoscopic view, half of the screen, please?
Окей. Вот аж. Окей. Это картинка көрінеді бұны масты камерадан? Yoki мампешni ko'rsatuvchi? So I need to
Don't know if it's on the screen, but my irrigation fluid is coming out of the sheath now. That looks good.
Салапсыз?
Yeah.
Suvni ochib yubordim. Suvni ochib yubordim. Men kelmayapti. Bo'ldi, keldi.
Дильмурат, вот профессор Петр Алкин спрашивает,
Вот,
почему в верхней чашке вы находитесь? Или ваши планы расскажите?
Потому что камень верхний, тут удвоение чашечной системы, внизу там камня нет, мы поэтому пошли сразу в верхнюю группу. Вот он там видно, сейчас я вот, который я смотрю.
Было бы лучше, вот сети показали, чтобы все знали, где, как располагается камень, а то
Нам
это непонятно идут. Почему в верхней чашке, почему снизу пошли.
Кратко объясню. В томографии, значит, когда мы уже наполнили контрастом, нижней группы там камней нет, верхней группы полностью вот это занимало. Поэтому решили, чтобы для безопасности сперва сделать ретроградно, флексивом посмотреть, потом уже делать доступ. То есть под контролем, как говорится, и зрения, и что мы правильно попадем. И показать как бы возможности можно и этим способом. Потому что там была еще тоненькая шейка, можем ли мы через эндоскоп зайдет или нет, я имею в виду жесткий эндоскоп. Поэтому решили с двух сторон как бы работать. Это получается у нас ESRS получается, да? Вот видите камень, да, я уже доступ не сделан, я сейчас здесь буду работать трилоджи уже, а Томас будет работать снизу, и я думаю, тогда уже будет побыстрее все у нас.
Обычно при эндоскопе комбайн глубина проникновения, да, вот пунктирование, дилатация, частично используется флюороскоп, а большинство под эндоскопическим контролем, да, вот, контролируется. А вы как сейчас больше
мы здесь
ориентируетесь на флюороскопом?
Да, и этот, по-моему, ну я, если честно, сделал так доступ сразу, поэтому не могу сказать, что как типа методом Булай, да? Нет, такого мы не делали, чтобы под контролем эндоскопическим делать панчер. Поэтому здесь мы, так как камень все-таки большой, не маленький, решили все это делать перкутанный доступ тоже. Yoqilgan? Is it ready? Окей, я понял. Сейчас я приготовлю все оборудование, и мы начнем работать. Yeah, chunam. Are you okay?
Yeah, okay. That's all good. I just started to laser a little. You see, it's a very soft stone, even with this setting, it's more like busting what we do.
Küçük ben ortadan akısıyla bölelim mi? Kazanmış. Evet, kazanmış. Sen ortadan kalkıyor. There is a little bit back. Okay, ready? Ready? This one? Can I use? Так, я здесь начинаю сейчас уже работать трилогии. Попробуем, что за машина.
Это получается камень верхней чашки, так?
Да, это, скажем так, в верхней группы мы доступ сделали. Не одна эта чашка, а... Принцип получается у нас какой? There's a crushing the stone and suction.
Какой метод дробления вы используете? Там, я вижу, там EMS стоит. Это лазерное дробление или
Опа,
какое-то сочетание пневматики?
сломался у вас этот.
О,
Я же говорю, very thin. See?
Yeah, that is the problem.
Да.
The problem with the thin probe is that it easily breaks. So what I do is, I learned this from Evangelos, is keep it like this with the handpiece, because the new handpiece from EMS comes without this clip, because it always breaks.
Okay, what we... Oh. Hangi kanalını beğendin? Ya yok o bitti. Bam.
Thomas and Dilmurad, can you hear me?
the
Kanal
pneumatic
ağrı ya.
probe is broken now.
Kanalını utadım. Kanalını verdi, almıştı. Мы
Dilmurad,
поменяем сейчас у нас тут все, что можно, как говорится, случилось. То есть сломался и flexible, мы его поменяли, сейчас Томас работает. У нас зон очень тоненький, хрупкий, он тоже, вот видите, сломался. Теперь меняем на более толстый. Посмотрим, как это будет у нас работать.
And just for your information, when I have changed the flexible scope,
Я думаю, на самом деле очень хороший мастер-класс, потому что вот идеальная ситуация, на идеальных ситуациях никто не учится. Именно вот такие моменты делают хирурга хирургом. Находить выход,
Да,
выходить
я
из
думаю,
ситуации и
здесь
так далее.
can you increase?
красиво. Нету, ну, как бы.
Someone use the laser setting?
Красиво все могут, а вот когда проблемы, вот
Is there
не каждый
anyone who
может.
knows about the laser? Yeah? Can you increase the energy diffusion on the left side?
Просто воду еще не
Yes. Two.
Да, вуна.
Two.
Ты не был?
Two.
Хорошо, я сделал, да.
Yes. Thanks.
Yeah.
Yeah. Good.
So,
Так, мы готовы. Поменяли зонд. Как говорится, дальше идем, будем дробить. Но он, наверное, здесь будет не очень хорошая ирригация, потому что он будет, наверное, перекрывать. Ну, посмотрим. То есть мы сейчас фактически... Надо. Ну, в принципе, есть.
Посоветовал перевернуть,
Да.
вам удобнее будет.
Ну, ладно, сейчас уже... Вот Томас там дробит, я здесь дроблю. Сейчас, наверное, как говорится, встретимся. Возможно, здесь я... почему сломалась? Может, где-то я руку неправильно держал, то есть надо всегда зонд, чтобы он не перегибался. Если я вот так буду перегибать, под давлением она может ломаться. Поэтому всегда надо контролировать. Особенно я прошу медсестер, чтобы, когда увлекаешься работой, можешь контроль потерять, поэтому они говорят, отсос работает, а? Отсос работает?
Профессор Петр Алкин подсказывает, можно вот этот flexible ультраскоп использовать для ирригации. Дильмират.
Ну, у него access sheet, то есть там, да, и, видите, он как бы, давление не повышается, все, что лишнее, выходит через вот этот антиградный доступ, через мой доступ. В принципе, я сейчас могу уже фрагменты, которые они спокойно могут зайти. Фрагментируем и потом это сделаем.
Is it possible to have the other screen, the flexible ureteroscopy screen as well?
Ko'rsatvorim, ham skrinni ko'rsating qo'lingizda.
Both endoscopy
Вот,
screens?
видно эндоскопическую картинку?
Вот интересно, да, пневматический EMS компания новая, это дробит совсем по-другому, да, доктор Дильмирот?
Да, тут...
Наподобие лазера дробит, фрагментация слишком маленькая.
Да, как ультразвук вот, дробит он. Вот, я вывожу без, даже не используем щипчики. Да? Вот. Вам видно, да, моя картинка, вот, на которой я работаю?
Да, вот эффект дробления совсем иная.
Не, вот сейчас вывожу. Көріп камера? Окей. Вот большие фрагменты, они спокойно выводятся через, у нас вот 16-й шарьер, да, вот мини, через выводится. Сейчас большие фрагменты мы тоже опять раздробим. Вот эти большие. Дальше. Да.
Дильмурат, попробуйте держать вверх ногами в порядке.
Мне неудобно. Подержи, вот так подержи. Я хочу вам.
Дильмурат, меня слышно?
Да, слышу.
Вот попросили объяснить, вот сейчас какие проблемы происходят, и ваш план рассказать. Потом мы должны здесь перейти на презентацию Петра Алкина. Если во время операции у вас возникнет вопрос или захотите показать, мы можем обратно вам на связь зайти.
Понял. Сейчас проблем нету. Надеюсь, проблемы у нас закончились. Работаем, то есть мы уже фрагментируем. Вам видно, наверное, эндоскопическая картинка. Большие фрагменты делаем. Насколько возможно, Томас будет дробить флексиблом, но я думаю, основные работы будет делать при помощи Endourology, все это раздробим. Сейчас проблем нету.
Тогда мы временно с вами прощаемся, но если у вас хороший момент наступит, вы можете на связь выйти, а по конце презентации мы обратно на вас выйдем. Пойдет так?
Хорошо.
Пожалуйста, презентацию включите, пока отключите Live Surgery.
So, you all know the complications: fever, bleeding, residual stones. I don't want to go into details about that. However, these authors, they wrote, all the papers were very heterogeneous. The management strategy of the complication was not reported, and the adverse events were not characterized. What does it mean? It simply means, and they said, future research is needed to improve patient counseling and potentially the strategy for their prevention. In essence, the summary of this review was that we don't know anything. I looked at PubMed publications until April this year. There were 6,300 publications on percutaneous, 3,800 mentioned also the complications, and there were only 3 papers that you find in PubMed talking about percutaneous and mistakes. So we write a lot about our complications, but we do not know the causes, we don't write about the mistakes. So 50 years after introduction of percutaneous, this signals an old, big contouring complication of percutaneous, not related to the procedure itself, but to our honesty, obviously. So, are complications just collateral damages from the P&L war zone? Or what about patient counseling? If we don't know our mistakes, but we tell patients about complications, what is an informed consent that the patient has to sign? Who is informed? Are we as urologists informed about what we are doing? Or can we just tell the patient, well, there are some complications, unfortunately, I don't know how they happen. So this is not really honest, I think. Do we hide our lack of precision and our inaccuracy behind the informed consent formulas? So the big question, read and listen to the words of the masters of the past in order to shape the future. I would like to dig big question mark behind it. Is it not better to read and listen to the words of the young one in order to understand the present and shape the future? So, the young ones are close to the beginning of the percutaneous learning curve, and they are close to the mistakes. I mean, I started at 50 years ago. Nobel, when did you start? Nobel, when did you start percutaneous? 10 years ago. 12 years ago. So he is much closer to the mistakes, and you, the young ones in Uzbekistan, are also closer to the mistakes. You should know. So I looked at the publication submissions per country in last year. In the British Journal of Urology from Uzbekistan, they were not among the first 2,000 submissions from 30 countries with at least 6 submissions. Uzbekistan. I also had contact with the World Journal of Urology and the Urology journal, and there were less than 0.2% submissions from Uzbekistan. This is a handful of publications. So you are such a strong country, you are advancing with high speed. Why don't we hear from you what the mistakes are? You are close to that. You are beginning. So write about it. Uzbeks, why can no urologist profit from your experience? And on the other hand, I looked also at the downloads from the British Journal of Urology from Uzbekistan. And you see between 2021 and the beginning of this year, Uzbekistan downloads in frequency moved up from the 95 position to the 59 among 235 countries. So you are reading, you are looking at the literature, you are looking at what people write. But I think it is very important that you start publishing. Why don't you publish even though you are reading? Well, as a review editor together with Matt Cooperberg from the United States, I could give several reasons why you don't publish, but you all know better why you don't publish. And try to find out what you can change. It is not the 80% rejection rate of all 3 journals. Of course, they reject paper, but you didn't submit papers. So why don't you sit down and write about the daily problems you have? And I would like to stimulate you, to provoke you to create your own internet-based publication system. I would say create a Central Asian free access urology portal with a new style and a new climate of scientific communication, written and styled and done by people at the age of 30, 40, 50, not 60. Maybe you, from time to time, you ask somebody who is 83 like me, and then I will try to assist you. Communicate and discuss urology with the complications and the mistakes. Remember, you do not learn from complications, but from mistakes, your own and those of others. To the young space, do it. It is not impossible. Impossible is not an argument. This could be your LOLO, Central Asian Urology Access Internet-based journal. Here you are in the center of the globus. And to the old one, I say, assist the young one in achieving this. Get rid of this terrible impact factor, which has lost its significance because it has become a value itself, not a measure anymore. And create the AU, the Central Asian Urology Factor. Do it. Start renovating and changing the publication system, and don't look at the complications, but look at the mistakes and change the mistakes. Thank you for listening.
Live surgery. Пожалуйста, подключите этот операционный блок. Доктор Дильмурат, слышно? Дильмурат? Дильмурат Ака? Пожалуйста, связь с операционным сделайте звук. Дильмурат. Томас.
Hello.
Мы
Да,
обратно
слышно?
с вами. Да, расскажите, у нас 2-3 минуты всего.
Okay, Thomas, okay.
Yeah?
We are reaching each other.
Yeah.
You see?
Yeah, but I wait now because I can't disintegrate
Yes.
if you do. So you're more effective. I wait for you.
Значит, мы продолжаем дробить камень. Здесь вот видно, да, вот моя картинка? Вот здесь эндоскоп гибкий, здесь камень. Поэтому сейчас я работаю, а Томас пока ждет, потому что у меня более эффективно. Поэтому так вот пока продолжаем. Трилогия хорошо, эффективно работает. Тут и принцип отсоса работает. Поэтому визуализация отлично.
Whenever you have the chance, you prefer to use Trilogy instead of laser because it's more effective.
Yes, more effective because of this big star horn. That's why we decided here use in PCNL we use Trilogy. But Thomas using?
It's same for me. So Trilogy is my preference for PCNL. I rarely use laser for PCNL only if I have specific indications where I expect to use a flexible scope. But usually I go for Trilogy. I don't do the very small sizes like they do here with 16. So my smallest size is 18, and if I do such a case, I usually use 24 French, and the advantage is that you can use bigger Trilogy probes, which are more effective, and especially for the L optic with 24, you have better suction, or you have suction.
That's a good
Now
information.
I'm helping Thomas just it's easily to remove all fragments. So irrigation is good. That's why.
That's an advantage that I flush in. And you easily
it's
get it
flushing out.
Yeah. Don't know if you can see it, so it's a lot of fragments on the tissue.
Yeah, you see it's here clear.
Oh, that's a nice presentation. Cesar Scrofone would be happy to see you.
Yeah. Thank you.
We're happy to see each other. So we were lost just 1 meter next to us, but we found each other again.
Okay. Thank you. We'll still work here.
That's true.
Huh? Вот видно, да, здесь у нас flexible. Вот теперь я работаю сейчас. I still work with this stone.
Доктор Дильбанат, если не особенности есть еще какие-то планы особенные?
Нет, раздробить, а потом стенд поставим. Если есть необходимость, будем нефростому ставить, посмотреть. Если кровотечения каких-то еще нет, уйдем без нефростомы, будет tubeless, only we put the stent.
So you will
Я думаю, особенностей не будет.
So you inspect the whole collecting system to be sure that there is no residual if you do no nephrostomy. Huh?
Yeah, we just see if it's no any kind of bleeding.
Except no bleeding,
we just put the stent.
Except no bleeding and no residuals. Are there other causes that you would like to have if not putting in a nephrostomy? For instance, I mean...
No, I think it depends. The puncture we did directly to calyx.
Yes.
That's why I think we don't need to use the nephrostomic stitch.
Do you know if the urine of this patient was infected?
No, it was clear.
Was clear.
Yeah.
And it's not an infection stone. At least not a screw.
Okay.
Ильмурадако, у меня такой вопрос. Мы знаем, что вы
Да.
больше практикуетесь на supine position писения. Мы знаем, что walking space, вот рабочая зона, меньше по сравнению prone position. И трансдюсеры, датчики ультразвука раньше, они большие. Для мультитрак писения supine, они очень неудобные, да? Вот. Как вы думаете, под ультразвуковым контролем для вас удобно или под рентгеновским контролем удобно в supine position?
Ну, практика, сейчас из практики своей собственной, могу сказать, что мы 90% операций на взрослых, я имею в виду, детей мы делаем всегда на прон, а у взрослых 90% даже какие-то коралловидные мы делаем на supine position. Потому что, как я сказал, вот этот, здесь главное, я думаю, есть хороший доступ и будет достаточно пространства вот для, видите, вот если я могу манипулировать тубусом. И вот когда идет, мы вот не используем, скажем, щипчики как-то, да, и слив жидкости, оно всегда идет вниз, так удобнее, чем в проун. Извлечение фрагментов, там уже будет чуть-чуть больше времени занимать и так далее.
Good.
Поэтому
Dilmurad,
мы где-то 90%, что мы на supine position делаем.
Dilmurad, thank you very much. Many
Да.
thanks to you and Thomas. You showed very well how a complex case should be approached and how you sort out problems during surgery. I think you deserve a round of applause from the audience. Thank you.
Thank you.
Okay, thank you.
Thank you to the chairs as well.
Мы прощаемся, отключите, пожалуйста, и вот следующую презентацию будем.
Again? Really? What? Really?
We'll continue our presentation. As Dr. Adim John already made your presentation in our last session, the next presentation is from guesswork to control, modern pressure monitoring ureteroscopy. The Professor Hee-Seung Ying Lee from Taiwan. Please start.
Thank you very much. Good afternoon, everyone. I'm Dr. Xiaoyan Li from Taiwan, Kaohsiung Medical University Hospital. And thank you for your invitation. It's really my honor to be here to talk about this topic, the modern pressure monitoring in ureteroscopy. And today I will talk from guesswork and to the control for the better, safer surgery. Today's outline, first I will explain why we need pressure monitoring, why the pressure monitoring is important. And also I will talk about the main factors influence the pressure during surgery. And also I will mention about the renal compliance. And then finally, I will introduce the concept of the passive observation from the passive observation to the active control. And also we'll talk about some novel, non-invasive intrarenal pressure monitoring device. And pressure matters because it directly related to the surgical safety and the post-operative outcome. Because if the pressure is too high, it will increase the risk of urosepsis, which is related to the elevated inflammatory parameters. And also it will increase the post-operative pain, long-term renal damage, and even collecting system rupture. So I think the pressure matters during our surgery. And this research gives us our clear picture about the pressure change throughout the procedure. Actually, pressure is not constant. It will change throughout all our surgery. And you can see the pressure even will become high during our active irrigation. So the high intrarenal pressure will increase the urosepsis and also prolong of the hospital stay. And I want to show you that not only the pressure, the absolute absolute pressure, the exact name, and also the fluctuation and the change of and the variation of the pressure also very important, which will increase the risk of urosepsis and also the postoperative pain. So we already know the relationship between the intrarenal pressure and the intrarenal backflow. You can see if the pressure is too high, it also will increase the kidney rupture. So clinically, we will set below the threshold, below the 40 millimeter mercury, and you can see the MRI demonstrate in a pig kidney. When the IRP increase, it will also increase visible intrarenal backflow. It's a trimester. And this slide I want to show to you about some mechanism, how pressure-related injury our kidney during our surgery. It includes the pyelovenous backflow, and it will increase the fluid absorption and leading to electrolyte imbalance and also the cardiovascular instability. And most important, I want to mention, and when we do the RI surgery for the UTUC, the high intrarenal pressure maybe will increase the risk of the tumor seeding. So I think not only the stone surgery, also the cancer surgery, the high intrarenal pressure is very important to control. So what factors will impact on the intrarenal pressure? We need to keep the concept because the pressure is the balance between the inflow and outflow. At the inflow, the type of irrigation system or renal compliance, renal anatomy is the key factors. And for the outflow, the ureter sheath, fans, or the scope size, working channel, or will determine the outflow resistance. So actually, I want to mention the concept of the renal compliance. For in the normal kidney phase, actually the nipple-shaped papilla will compress and have an anti-reflux mechanism to present and protect the interstitial tissue. However, if the kidney have a poor renal compliance, such as some spatial condition, sepsis, hypotension, hydronephrosis, or papillary anatomical abnormalities, which will damage the papilla structure and will destroy anti-reflux mechanism, which will increase the kidney injury and make the kidney more vulnerable. So we need to consider this kind of poor renal compliance situation. This slide want to show that the resistance equation. You can see the intrarenal pressure is mainly determined by the outflow resistance. So if we have a modified ureteral access sheath to keep the outflow good drainage and good patency, the intrarenal pressure will keep lower and keep the safer threshold. So I also want to mention the kidney have a two-phase pressure behavior. In the beginning, actually, at the lower irrigation, even at the lower irrigation rates, the renal collecting system also can stretch. And then you can see the compliance phase, the pressure rise non-linear. However, if the kidney enter the isovolumic phase, it means when you even increase a little irrigation flow rate, the pressure will increase rapidly and sharp and linear phase to get the pressure spike. So it's more dangerous when the kidney enter to the isovolumic phase. So this slide, I want to mention some special case which is more vulnerable, which means this kind of patient will have a higher risk of complication after the surgery in the high intrarenal pressure. So for these concerning patients, I think if we can monitor the intrarenal pressure during our surgery, and it will even more valuable for this kind of patients. So I want to introduce some novel, non-invasive pressure monitoring device. And from this paper, there is upper two picture that show it's the flexible ureter sheath with a pressure measuring sensor. And the lower two pictures are the intelligent intrarenal pressure system, and the pressure, the sensing is connected to the catheter or the suction sheath. So it is automatically can change and monitor the intrarenal pressure, even intrarenal temperature. So when compare these pressure measurements with the UDS as a reference, you can see it shows strong intra-class correlation and compared with the UDS study. So I want to share our experience in my hospital. In my hospital, we recently have this whole reusable scope. During the surgery using the scope, it can monitor the intrarenal pressure and the temperature simultaneously. So this is, I will show some video when I doing the surgery. Left side, you can see I use for this case, I use the deuterium fiber laser. Of course, we also have a Homi-Yaga laser. But this case is deuterium fiber laser, and you can see it from the monitor, left up side. You can see the scope can record real-time intrarenal temperature and pressure. And of course, he can sound when you go over the threshold. It was set 40 degree and 40 millimeter mercury. But although they cannot have sound, but the number will turn into the red color. So you can see, oh, you are over the threshold. And also the right side is, because in my hospital, we usually use fans, suction sheaths. And during the suction sheath, you can see in the monitor, the intrarenal pressure is quite low or even minus a lot. So you can see the change and then the fluctuation of your pressure during your surgery, and then, which will keep your surgery more safety. Okay. This is the case with renal pelvis tumor. I use the deuterium laser to do the tumor ablation. So I also can use the whole scope to monitor our surgery and real-time intrarenal pressure and the temperature. For the, I think for the tumor ablation, we also confirm about the intrarenal temperature. So I think for me, it's a good monitor device to help us to monitor if we keep the patient's safety. So my conclusion is, I think high intrarenal pressure is very important because it can lead to a severe post-operative pain, infection, sepsis, and even the kidney rupture or hematoma. We also have some experience about this kind of adverse effect. So we need to keep the balance between the inflow and outflow. It's most important to keep the intrarenal pressure below the 40 millimeter mercury. Thank you for your attention. It's my talk. Thank you.
Thank you so much. We don't have time for question. Next presentation from.
Thank you for your presentation. I can.
We don't have time.
Can I add some comment?
Yeah, thank you.
Of course, it's very important factors for our preventing complication pressure. But sometimes in complication cases, we should artificially increase our intrarenal pressure, especially during the bleeding. Yes.
You mean you want the operation feel more clear? You need to up your irrigation rate, right? Yeah.
Yes.
Yeah. So I think the most important is the outflow. So we need to keep the outflow more good drainage, not the outflow resistance must be low. So I think it's okay. Even you adjust the higher irrigation rate, you can keep the balance in intrarenal pressure. So I think the RESP, the ratio between the scope and the sheath, is also very important.
Thanks so much. Next presentation from Professor Oliver Traxler, the basic medical stone management, what every urologist should know.
Okay, so my disclosure, the same. Okay, so now we are talking about medical. I'm not sure that this is your favorite topic. Usually, when I'm talking about this metabolic evaluation, most of the people, they are not very happy. So I will try to make it as simple as possible. And you know that if you go to the guidelines, so if you go to the European guidelines or the American guidelines, I must say that it's not so easy to understand. If you look at tables like that, coming from EAU, you need to be a little bit expert and passionate to learn and to know about all these tables. If you go to the American guidelines, it's not much better. You know, you have plenty of pages like that, so you need to be very awake to understand and to learn about that. Oops. Okay. Look at this. They are stones, kidney stones. But the question is, as a urologist, are you able to give the right name for each of them? Ask yourself if you are able to give the right name. This is actually the right one. Calcium oxalate monohydrate, dihydrate, cystine stone, uric acid, and the combination of uric acid and calcium oxalate monohydrate. If you are already able to recognize the stone during the treatment, you have already some ideas in terms of medical prevention for most of these stones. So it's very important to be able, as a urologist, to recognize the main type of stones. If you would like to learn a little bit more regarding the stone classification, I would strongly recommend to have a look on this paper from Michel Dedon. Michel Dedon is a biologist, a French one, and he described a very interesting stone classification. And for each stone, he is making some comments regarding the medical treatment. Keep in mind that we moved in the last century from the stone from the left to the right. And if you look at these two stones, they are completely different. We are coming from urate and phosphate, but now it's calcium oxalate and mainly calcium oxalate monohydrates. What is the reason for that? Why this big change in the last century? And this is the explanation. You need to keep in mind that most of the stones actually develop because of the diet. It's not the problem of vitamin D or PTH. No, the main problem actually associated with kidney stone is the diet, and of course this kind of diet. You need to consider that in the last 60 years, we are taking many more in terms of animal protein, in terms of fats, in terms of salt, and the main problem is probably sugar. We increase actually by 30 times, which is enormous, and I will come back on that. So if it's the diet, as a urologist, we need to be able to evaluate the diet of our patient according to the stones. And to evaluate the diet, of course, we have some questionnaire. We can ask questions to the patients. For example, to know if they are taking milk or cheese. But we need also to confirm, and we need to evaluate. So what I would like to see with you in the last 10 minutes is these 6 items that we will evaluate in one simple, single urine collection for 24 hours. Why do we look about creatininuria? Why do we evaluate creatinine into the urine? Just to be sure that the patient collects well the urine for one day, that he was not missing one time to urinate in the bottle, or maybe urinate more than 24 hours. So you need to be sure of that. And to be sure is very simple. You ask the weight of the patient, you multiply it by 20, and you are supposed to find exactly the same number in the results. So for example, if you are 70 kilo, you multiply it by 20, you obtain 1,400. You look at the results. If into the results you see that it's more or less 1,400, it means that he collects well. Look at this example. The guy is 63 kilo. So you multiply 63 by 20, you obtain 1,260. You check the results is 1,280. It's very similar. So it means that he collects well the urine for one day. So that's really the first point you need to do all the time. When you receive the results, you need to confirm it's a really one-day collection. So easy to do. You take the weight, multiply it by 20, and you compare. If the number is more or less the same, it means it's well collected. If it's more, it means that he collects more than 24. He did some mistakes. And if the number is less, it means that he missed during the day to urinate in the bottle. So creatininuria, just to confirm it's one-day collection. Then you look at the volume. When you know that it's correct, you can have a look for the rest of the results. Total volume, very easy. If you are a stone former, it's an obligation to urinate 2 liters for all stone formers. That's due to the concentration. To dilute the urine, you need to reach 2 liters. If you are not a stone former, you can urinate whatever you want. But if you are a stone former, the limit is 2 liters. Very easy. And if you are a cysteinuric stone former, you need to urinate 3 liters, even more. But for all the patients. Fluids. How much should we drink and what can we drink to reach 2 liters? In general, all the fluids will participate to the total volume, of course. But we can maybe not recommend to drink 2 liters of alcohol. So, of course, it's very easy to recommend our patient to drink water, at least 2 liters. That's what we said, to produce the 2 liters of urine. Orange juice is something that you can recommend, especially for calcium oxalate stone former. Why? Because if you take 1 glass of orange juice every morning, you will increase the urinary pH. Many people are thinking, if I'm taking orange juice, I will decrease the pH. No. If you take 1 glass of orange juice, especially in the morning, you increase the pH. Something that we recommend, to be close to 6 with the normal pH. At the same time, if you take 1 glass of orange juice, you also increase the citrate. And as you know, citrate is a very strong inhibitor of calcium oxalate crystallization. So orange juice is a very good recommendation. You bring some fluid, some water, you bring some potassium citrate, you will increase the pH and you receive just what you need in terms of vitamin C every day, 65 milligrams, which is perfect. There's only one problem, sugar. If you take 1 glass of orange juice, you also take 5 pieces of sugar. So the reason we cannot recommend to drink 2 liters of oranges, just 1 glass during the morning. Coffee and tea, there's no restriction. For many years, we were thinking that tea is associated with hyperoxaluria. Now we know that it's not exactly the same. Tea is excellent in terms of fluid, and it doesn't increase the risk of calcium oxalate. Looking at stone analysis, you know that these 2 stones, the name is calcium oxalate, but they are very different. Why? Because the one of the left is calcium oxalate monohydrate. Monohydrate depends of too much oxalate in the urine. Calcium oxalate dihydrate, on the right, depends of calcium, hypercalciuria. There are 2 different stones. We cannot talk about calcium oxalate. When we say calcium oxalate, we need to know if it's monohydrate or dihydrate. And you have seen this morning, the stone was dihydrate. So probably associated with problem in terms of hypercalciuria. It's easy to remember. Monohydrate, you have 2 O, like oxalate. Dihydrate, you have I, like calcium. So if you see a stone like this into the collecting system, you need to think about this is calcium oxalate monohydrate. So the main problem is too much oxalate in the urine. Why? Because low diuresis, it's a problem of concentration, or it's really hyperoxaluria, mainly coming from the diet. And you know this specific diet, like chocolate, cocoa, nuts, spinach, pepper, vitamin C, excess of vitamin C, more than 500 milligrams, Coke, and also less calcium intake. Maybe you know that if you are not taking calcium, you increase oxalate absorption in the intestine. So it means that you will increase hyperoxaluria. Different example regarding oxalate, but think about the main source of oxalate, dry fruits like nuts, almonds, and chocolates. They are very, very classical. This is also oxalate, but to be honest, we have very few patients taking this every day. We have much more patients taking dry fruits and chocolates, of course. This is the main problem. Dark chocolate, with very high percentage of cocoa. Milk chocolate is not a problem. Why? Because in milk chocolate you have milk. Milk is calcium. So if you take at the same time calcium and oxalate, you will not increase absorption of oxalate. So milk chocolate is not a problem. Only dark chocolate. This is full of oxalate. This is also full of oxalate. You need to know that if you like these jelly sweets is full of hydroxyproline, and hydroxyproline is a precursor of oxalate. So if some of you patients developing calcium oxalate monohydrate are taking this, they have probably to reduce. And they have to increase the fluid to reach 2 liters, and also to take calcium. If you develop monohydrate, you must take some calcium 2 or 3 times a day to compensate oxalate absorption. Regarding calcium, this is the typical stone associated with hypercalciuria. So if you see such kind of stone, and usually it's a woman, it's also possible with the man, but most of the time it's a woman. If you see this, think about hypercalciuria. It means too much calcium into the urine. If you look at hypercalciuria, this is the definition, you will find up to 40% of you patients with hypercalciuria. It's a very, very common problem into the urine. And it's easy to make the diagnosis. You do a collection of the urine for 1 day, you look at the calcium, if it's more than 250 milligrams per day, it means hypercalciuria. It's easy to make the diagnosis. What is complicated is to know why. Why the people are losing calcium into the urine. It could be just a problem of diuresis, problem of concentration. It could be also too much calcium. Very few reasons, simple reasons. People taking too much calcium, 4, 5, 6 milk products every day. This is not very common, okay? Most of the people, they are taking maybe 1 or 2, so they are not in excess of calcium. The main problem to produce calcium in the urine is if you are taking too much animal protein or if you are taking too much salt. You maybe know this is actually for the milk product. If you consider 1 glass of milk, a piece of cheese, a yogurt, each of them, it's more or less 200 milligrams. But you know that we need every day, each of us, we need 1 gram of calcium. So we need 2 or 3 milk products. This is not an excess. This is just the normal. Salt. Why salt produce hypercalciuria? Easy to understand. If you take salt, all the salt that you are taking is absorbed. It goes to the blood, and then you have too much salt in the blood. So the kidney will evacuate, eliminate sodium in the urine. It's easy. The problem is to eliminate the salt into the urine, the kidney is forced to eliminate calcium at the same time. So if you take too much sodium, you will eliminate calcium in the urine. So too much sodium means hypercalciuria. So how do you know if patient is taking too much sodium? It's very easy. You look at the results of sodium in the urine, 24 hours, and you divide by 17. So for example, if you look at this guy, the results is 160. You divide 160 by 17, it means more or less 10 grams of sodium. It's too much. We are supposed to take less than 7 grams every day. And remember that sodium is everywhere, everywhere. The second problem with sodium is animal protein. If you are taking too much animal protein, red meat, white, fish, eggs, sausage, seafood, that's animal protein. If you take too much, to metabolize animal protein, you are also forced to eliminate calcium in the urine. It's like salt. Too much animal protein means you will lose calcium in the urine. Just to make the message very simple. We are supposed to take 0.8 to 1 gram of animal protein per kilo and per day. How do you know if patient is taking too much? You look at urea in the results. You take this number, you multiply it by 3.5, and then you divide by the weight. If you obtain something more than 1 gram per kilo and per day, it means that the patient is taking too much animal protein. You look at urea, you multiply it by 3.5, and you divide by the weight. Doing that, you know if the patient is taking too much or not. Of course, sometimes it's not so simple. The problem is not milk product, this is not salt, this is not animal protein. Everything is more or less the same. In these very few patients, it means that it's a very complex problem in terms of metabolism. Maybe looking at PTH, vitamin D, or something more complicated. So if you don't find an easy explanation regarding milk products, salt, animal protein, you need to talk to the nephrologist. And the best one is this one, Charlie Pack. It was me, 1999. I've become much older now. But Charlie Pack, as you know, he designed the fast and calcium load test. It's a very complex evaluation to know exactly about hypercalciuria. So it means that as a urologist, you need to be connected to good nephrologists for those very complicated patients. Also, keep in mind that Dihydrate calcium stone, like this one, is calcium possibly is coming from the bone. So it's very important also to evaluate the bone density in such kind of patient. And there is a strong relation. Uric acid stone, what are the problems? Low diuresis, that's a problem of concentration. They need to drink more than 2 liters. The main problem is low pH, very low pH. And sometimes it's hyperuricasuria. pH, we have many possibilities to produce low urinary pH, like diabetes, metabolic syndrome, you know that. Main problem. For hyperuricasuria, it comes from, most of the time, from the diet. This is the typical patient on the left with the metabolic syndrome. The fat is into the abdomen. This is the abdominal fat. The patient on the right, it's not a metabolic syndrome. The fat is under the skin. It's different. The metabolic syndrome is on the left. And you see also the liver, the steatosis, regularly associated with this kind of patient. Uric acid should be less than 700 milligrams per day. Otherwise, you can demonstrate, you can conclude it's hyperuricasuria. It comes from this, of course, uric acid, but it also comes from this. Actually, the main source of uric acid is sugar. It's not animal protein. We have much more problem actually with the sugar. That's what we call the NASH syndrome. And finally, for cystine stones, it's a very complex situation. You need to manage this kind of patient together with the pediatrician and with the nephrologist. You can maybe not do it by yourself in terms of medical, but cystine stone is very easy to recognize today in terms of endoscopy. You know that it smells very special. We have endoscopic sign to recognize cystine, so don't miss cystine stone. So just the take-home message, look at these 6 items, one collection, creatinine, to be sure that it's a one-day collection, total volume more than 2 liters, calcium less than 250 milligrams, otherwise you can conclude hypercalciuria, sodium and urea to explain hypercalciuria, and uric acid in terms of metabolic syndrome. The second take-home message is when you look at this calcium stone dependent, think about bone density. There's a huge relation between the bone density and this type of stones. And if you have uric acid stone, you need to think about this problem, mainly the metabolic syndrome. This is the meeting that we will do in Valencia. Also to let you know that during this meeting, we will have a special session for 1 hour for the Central Asia Association of Urology. Thank you.
Thank you so much. We don't have time for questions. I'm sorry, so sorry. Next station. We have to start next station. This chair, Professor Laurian, Azim John, Thomas, and thank you for you. Ikram, Rahmat.
We'll start with thanking everyone who's in the room for your patience and for your enthusiasm. I really love the last lecture. It's probably one of the lectures that I always watch very intensely, because there are these things that we should actually do as endourologists when we treat our kidney stone patients. Azim?
Thank you. I would like to congratulate all of us to having the special session in the International Congress of Endourology in October. So special thanks to Olivier Traxler to making this chance, and then I hope we will do our best to show our capability and what we have right now. Thank you. Let's start the young urologist competition. So let's start the young urologist competition. Now I will announce our judges, and then I would like to ask them to sit in the first line. So Professor Olivier Traxler, Professor Shuhrat Mukhlarov, Uzbekistan, Ulanbek Jambek Ulu from Kazakhstan, Nurbek Monolov from the Bishkek, Kyrgyzstan, and the Maksat Aman-Nazarov from Turkmenistan, and Ikram Rofiev from Tajikistan. Я хочу анонсировать, что эта секция для наших молодых урологов, и хочу отдельно отметить, что приз за первое место путевка, бесплатная путевка в интенсивный курс по перкутанной хирургии, который пройдет в Кембридже. Так что пожелаем удачи всем нашим молодым урологам. Let's start.
So really looking forward to starting and hearing, listening to you guys. I would like to invite now Ermek Takibayev from Bishkek, Kyrgyzstan, to present a lecture on the role of shockwave lithotripsy in the modern endourology era.
Good morning, dear colleagues. My name is Ermek Takibayev. I am a urologist from Kyrgyzstan in Dok University Hospital. Today I would like to discuss the role of ESFL in the modern endourology era. The modern urology is developing the leaps and bounds. Can we say that the era is ESFL has come to end? To understand this, looks like the current trends. In the recent years, the number of ureteroscopic procedures increased. At the same time, the use of ESFL procedure declined. Over the past 25 years, the share of US procedure increased by 70%, and the share of ESFL decreased by 14%. But what the recommendation says, according to the current guidelines, ESFL and URS were the most commonly recommended procedure of all stone size and locations. Why the popularity of US ESFL has decreased? The main reason include variability of outcomes between centers and operators, rapid programs and endoscopic techniques, and changing patients and healthcare system expectations. What can be said in defense of ESFL? Need for general anesthesia and hospitalization and are major concerns for intensive approaches. Ureteral stent placement following ureteroscopic stone management is a commonly preferred procedure which in most cases seriously affects the quality of life patients. Despite the higher stone-free rate in patients with URS, the quality of life is lower than ESFL group. X-ray danger. even minimal radiation carries some risk. Watching colleagues in social media, in after operation, you can see Yekirs. I can say that some endourologists do not always following radiation safety protocols and often neglect thyroid protection when working with X-ray. Only 10% endourologists uses as ALARA protocol, only 15% of urologists were dosimeters, only 5% urologists had been trained the handling of X-ray generation. ESVL without X-ray wins here. Endoscopic in the trained highest generator of waste in healthcare and sector and significantly contributing to worldwide carbon emission. Only one patient with RIRS, we use one single-use URS, one guide wire, one access stis, and one double G stand, and ureter catheter, and gloves. That's a lot of waste. And ESVL doesn't have any waste. In my country, ESVL is very popular procedure because this is we are a little bit change technique while others move the hands of the lithotripter, we leave lithotripter in static and move patients. First, we look, understand, and find the best visibility of the stone, and after when we move patients, the stone and move patients so that the lithotripter and similar visualization. It is easier aim, achieves good fragmentation at stone and see every shock wave. Our clinic, we last 5 years we use ESVL procedures, 2,500 procedures in modulated SLK intellect system by Storch medical system. The patient's age ranged from 2 to 18 years, and the mean stone size 6.3 millimeter in the ureter and 9.7 millimeter in the kidney. The average stone density was 970 Hounsfield. All procedures were performed under ultrasound guidelines. The main indicators were recurrent renal colic and solitary uretral and renal stone in absence of urinary tract infection. After one session, stone-free rate was 67%. After second session, after 2 sessions, stone-free rate was 85%. How we see this? We use ESVL in distal ureter. This picture before is this picture after one procedure. This another patient before and after. Clinical case, patient 4 years old, 11 millimeter stone left kidneys, and we don't have use anesthesia and painkiller. This is how lithotripter see, and you see how we fragmentation stone. This is after before and after 1 week. Ultrasound guidelines is ESVL is a very safety. It's a very safe. It is non-invasive method for the treatment of urolithiasis. The stone-free rate reaches 85% after 2 sessions. The quality of life higher than is with ureas and non-carbon footprint. Ultrasound guideline completely eliminates radiation, exporting and similar with simple files the procedure. The technique is cost-effective and can be performed in the outpatients setting. If we use right technique and we use right patient selection, and extensive experience of the doctor, we improve the results. I can say the era of ESVL has not yet come to end. Thank you for your attention.
Thank you very much, Ermek. I think you deserve much more applause than this. First of all, for all the work that you've put in it. Second of all, and this is to for all the young guys, for the courage of being here, presenting, and trying to do this as a young urologist. It's not easy, and we, both as in John and me, and I'm pretty sure the whole room really appreciates your efforts. So congratulations again, well done. Now, we will take one question from the audience and one from the jury, but since we don't have anyone from the audience, we'll go directly to the jury. Perfect.
Thank you for your presentation. How you assess the size of broken pieces during the procedure? As if the pieces is large, after your procedure may be blockage, the upper urine tract, and make renal colic, and may be needed for repeated intervention.
We see control before procedure CT scan, and we CT scan, and we see volume, Hounsfield volume after procedure.
I mean during the procedures.
In procedures, we control only ultrasound control in all ureter and all kidney parts. After one session,
look. If English is a bit, and you can't express your ideas very clearly in English, we have translation, speaking Russian. That's okay.
Как мелкие частицы, да, вот дробим камни во время процедуры. Может быть, там большие частицы остаются, так?
Да.
Во время ультразвука они объединяются в одно.
Да.
Различить их очень трудно во время ультразвукового контроля.
Да.
Вот закончишь процедуры, думаешь, все отходят частицы, а вдруг какой-то частичок так закупоривает, придется заново процедуру или установить стенд до развития осложнения. Мой вопрос в этом.
Мы до процедуры, получается, во время процедуры мы видим же, как в принципе, камушки дробятся. Именно каждый удар, в принципе, там видно то, что камешек двигается, прыгает. И мы до этого, до сеанса, мы уже замеряем какие-то размеры. Потому что она бывает, то, что она бывает круглая, иногда овальная форма конкремент. Если конкремент круглый, мы, получается, измерили там, допустим, 5 на 6 миллиметров, после процедуры мы раздробили, и если он чуточку сдвинулся, потерял свою форму и уменьшился в размере, это уже говорит то, что мы уже, в принципе, камешек раздробился, камушек двигается и все такое. А если потом возникают какие-то осложнения, просто бывает то, что после первого сеанса камушек продвинулся на несколько миллиметров или на несколько сантиметров с верхней трети до средней трети. В принципе, если надо, нужно будет дробить, мы, в принципе, через 1-2 дня уже дробим, уже в другой локализации, потому что риска травматизации и то, что именно на одном месте дробим, это мы не дробим на одном месте, мы дробим в разных местах, получается.
Good. So thank you very much again. Well done. Congratulations. And I'm grateful to the room for their support. Again, these young guys really, really need your support, and they are very brave to do this and to be here. So we'll move to the next.
Thank you, Ermek. So next presenter is a representative from Kazakhstan, from Astana, Erkebulan Muhambetov. He will talk on the fluid dynamics in endourology, why flow matters.
Hello everyone. I'm second year urology resident in Astana, and I may be too young for more of them, but my theme is fluid dynamics and urology and why flow matter, because I think that's interesting area and maybe in the future it may be investigated. My conflict is interested. Okay, sorry. My conflict is interested is absent, and everyone knows that flow matter and normal internal pressure is less than 10 millimeter for mercury, and if you increase this internal pressure over than 30 millimeter of mercury, you have some serious complication like infection complication, and because irrigation with toxins can backflow to the blood, and you increase the infection complication like urosepsis. And in resurgery, irrigation is one of the crucial components, like ensures visibility and procedural efficacy. And speaking about the irrigation in the endourology must begin with Posey law. What is Posey law? Posey law is a mathematical expression to calculate the flow rate through the tube, and Posey law states that you can directly proportional the pressure gradient and flow power of radius, and inversely proportional to the viscosity and length. What that means for us, because we work in the tubes, you control these parameters in every day in your practice. For example, it's about pressure gradient. Pressure gradients is different between your inlet and outlet. For example, when you increase your back or pump, you increase at P1. When you outlet, if you use standard relaxation sheets, it's your tip, proximal tip of your sheets, or it's negative pressure. A second component of this Posey law is length, it's tube and working channel. According to the Posey law, it's your length is long, your flow is decreased, and third dominant factor is radius of irrigation tube and working channel. Why is the dominant factor? Because according to the Posey law, if you increase it 2 times, you increase the flow 60 times. And last component is the viscosity of your saline. If your saline is high, your flow decreases. And of course, we understand that Posey law working only in ideal system, but in our real clinical practice, it's different. And with some gaps, some limitation of this Posey law. First is turbulent flow. According to the Posey law, your flow must be parallel, but in real clinical practice, your flow is chaotical, turbulent. And what about fluids? According to the Posey law, your fluids must be Newtonian, but in the clinical practice, non-Newtonian, because when you do lithotripsy, you have some dust, clots, and debris, and your flow became a bit non-Newtonian. And according to Posey law, your radius must be rigid cylindrical, but everyone knows here that ureter and pelvic iliac system is distended. He not have renal pelvis stiffness, have elastic tube. And in these slides, you can see that the scheme of between the physics and anatomy. In the left side, you can see that scope inserted to the pelvic iliac system, and flow from the scope outflowed by the gap between the scope and sheaths. On right side, you have this scheme of differences between resistant inflow and resistant outflow, and you need to know that your resistant inflow and outflow must be different, because if you want to good visibility and low internal pressure, your resistance outflow must be lower than resistance inflow, and it's physical why you use rotational axis sheets in our practice. The first publication this year about fluid dynamics, it's from 2018, about how renal cavity influences on this. And according to the Oratis publications, the pelvis compliance, its coefficient is 0.41. What it means that if you increase the irrigation pressure for 10 millimeter in renal pelvis, you have increased the internal pressure by 4.1 centimeter for water. And one of the results of this publication is that annual gap between scopic sheets is one of the dominant factor. What's now new publication say about it? This publication from 2026 from Williams, and look at the table, you see that you have two cases with the same fringe and frame RSD. RSD is ratio between endoscope and sheets, and according to Funk publication in 2019, he said that recommended RSD is lower than 0.75. And you have two cases. First cases, you have same fringe, but outflow area is different. In first cases, outflow increased by 24%, but in second cases, you have same RSD, but outflow area is different, and outflow increased by 45%. And this recommendation of this after that optimal outflow resistance, it was be 0.29, 0.39, but too low outflow resistance is not good for us, because it's counterproductive, because you need more high pressure, increased irrigation, and if you do precise lithotripsy, your unwanted stone movement you have. And of course, improved outflow could reduce the internal pressure. And this one of the interesting publications in this area is the fluid mechanics of rotoscopic irrigation. It's some interesting parameters. First is tip deflection. Tip deflection increased the outflow, but reduced it only 5%. And if you change the elliptical working channel from cylindrical, your flow increased by 50%. And about the gravity, gravity is overestimated after 60 centimeters of water. Why? Because according to the Pauli law, if you increase the pressure gradient, you increase the flow, but after 60 centimeters, Pauli law not working, not working directly. And everyone knows that if you have something in your working channel, your flow is decreased, and fiber optic in your your working channel is important too. Why? Because it's your fiber in the center in the work channel, your flow decreased by 25%. And of course, to calculate these parameters in real operation in heart, and okay, we have a good outflow resistance, good outflow, and what happened in renal cavity. And this computational fluid dynamics show us that in real practice, we have stagnation zone and vortex traps. What is stagnation zones? Stagnation zones is zones where your fluid not move it, and if your dust or cloth or duff or debris can put in these zones, he's not moved. And vortex traps, what it means, if you have high flow, your stone moved in this vortex trap, it can wash out. And if most of the urologist increases his flow for better clearance, but real clinical practice, according to the stagnation zones, vortex traps, he can wash out effectively. It's another publication in this field from 2023 with CFD analysis. It's a real patient with CT reconstructed pericardial system, and we see that some stones wash out, but some stones trapped in the calyx. And what it means that anatomy of pericardial system is not modifiable important factor, because anatomy of pericardial system is so divided, so unclear, so many classifications exist. And I think that this factor have missed in some publications. What is this interesting publication about the faster pullback speed? In fans, you need a minimum effective flow rate after 50 millimeters. And stone movement is driven not by pressure, by the vortices. And in this publication, we see that stone movement model by acceleration, uniform speed deceleration, and high flow with larger RSD give us faster pullback speed. But if you have 20 millimeter for water and RSD 0.87, you have pullback speed. It's 20 centimeters per second. It's very fast. But this paradox of RSD is that you higher ratio of RSD, but we know that higher ratio is bad for outflow, but good for pullback speed. And some technical solution can solve to these problems. For example, with no hydrodynamic design, when you created...
We'll give you another 30 minutes, 30 seconds.
Thank you. This publication created the eddy in your stone debris clearance increased by tenfold. It's with same internal pressure. And in the world, used so many different gravity system or pump systems, so many irrigation system. And what's our next? I think our future is automatic fluid management. It's according to Manuel's publication. It's publication from Zhu from 2025. You remember this traditional reactor sheets, fans, internal monitoring fans, and second, it's internal monitoring fans.
Thank you.
Last
time
question.
limit.
Sorry.
You should follow your time.
Since it is a competition, it's not, you're not
Yes.
like the other speakers, and it's not fair to allow you more time, but it was a very good presentation. So congratulations. Now stay, don't run away, don't run away. We have 2 questions. So, question from the audience, please.
Sorry.
No worries. Shavat, please. And then we will take a question from the jury.
Thank you. Can you hear me? Thank you. It was a really nice presentation with flow limits. And I would like to ask you, as we endourologists are continuously moving around the calyceal systems, you said about a space that is like a dead space, so no movements of particles are happening there. What would you recommend for that kind of spaces that vortex do not exist? Would you recommend to move the flexible scope or stay, or what would your opinion be about that?
Sorry, Professor, I can listen to your question because too low. Maybe I be...
So, can you hear me now? You said about stagnant areas of the flow that are not moving when you are stable of the flow of the vortex.
Yes.
So what would be your recommendation be for the flow to continue all over the calyces?
You mean how to break the vortex traps?
Yes.
According to one of this, I not say that, but in this publication says that we broke these traps with the movement of the scope. When we move it, the trap, this vortexes, it became different. But according to when I say early, periodic system is very divided, and maybe you have narrow calyx, and you can put in there, and maybe you can influence this calyxal. And it's I think that it's not the limitation of our scopes of devices or urology. I think it's a factor of patient like BMI or another. But we can recommend it to patient with BMI to decrease it. But his anatomy, we can do anything. It's my answer for your question.
Good, thank you very much. One question from the jury, please. We need one. So, what can you think of to ask? I think Professor Alken will ask the question. Thank you, Professor.
Very nice presentation with a lot of data, very good. My question is, during all the studies you've done to prepare this, have you found data on continuous flow instruments? Because they maintain a continuous inflow and outflow without complicated devices. Did you find something? If not, it's just my experience because I'm old and you are young. Continuous flow. You know, continuous flow instruments have been used in the bladder for TUR prostate or TUR bladder tumor.
Professor, can you help me translate for Russian maybe? Because I'm not
basically the same
really
type of
understand.
flow, inflow and outflow through the same instrument.
So,
он спрашивает, что у тебя есть ли какие-нибудь данные, научные данные про инструменты, которые имеют как бы
приток и постоянный отток.
Outflow, да. Постоянная ирригация.
In my presentation, I concentrate only on RIS, but these laws work in PCNL surgery, work in transrectal surgery, and of course, one of the first publication from 2008, about the continuous flow in the cystoscopy. When we have continuous flow, it decreases your resistance, and continuous flow increased in this year, increased your visibility. And of course, continuous flow, I think it's key component of our devices. It's because we work in new era. Because when I started the urology, suction systems exist. You started in another era where suction is not developed. You developed it with another pro-urologist.
Good. Thank you very much again. You deserve all the applause. Very good presentation. Thank you. Now, the plan from here will be that we will take one more presentation from the juniors, then we will have the online lecture from Professor Liatsikos, and then we will finish with the last two presentations from the junior doctors. So I would like to invite now Nuri Hojamuradov from Ashgabat from Turkmenistan. Nuri, thank you for being here. Thank you for being brave. You have to fit in 15 minutes, and you have the tracker down there.
Okay. Assalamu alaikum. Thank you so much. Today, let me introduce about my presentation about the importance of the mini percutaneous nephrolithotripsy in the treatment of urolithiasis. Currently, urinary stone disease is among the most common disorders. In my country, it ranges between 7 and 20% from all of the diseases. Some forms of renal urolithiasis include large kidney stones more than 2.5 centimeters or coral-shaped calculi, staghorn calculi. Following of the recommendations and guidelines of EAU, we perform percutaneous nephrolithotripsy at the first treatment of large kidney stones. With the introduction of modern and diagnosis and the treatment methods into clinical practice, minimally invasive surgery approaches have increasingly been preferred in the management of patients with urinary stone disease. Owing to advances in modern technology, mini percutaneous nephrolithotripsy becomes the most important operative techniques for the treatment. As we have know about the guidelines and notices, first way in the treatment of urinary stone diseases, if kidney stones more than 2.5 centimeters and more than 1,000 Hounsfield density in computer tomography, we could choose to make percutaneous nephrolithotripsy. But if we have kidney stones in the downsides of calyx, we could choose only the mini percutaneous nephrolithripsy. Aim of the study to make to evaluate importance and specific features of mini PNL as a treatment. In Turkmenistan, we introduced mini percutaneous nephrolithripsy in May 2021 and in International Endocrinology and Surgeon Center. We selected 89 patients from underwent mini percutaneous nephrolithripsy. 51 of them were male and 38 of them were female. We detected in the right side 40 times kidney stones and the left side 49 times kidney stones. We selected patients aged between 16 and 65 years old. The mean age were 41, 34 years old patients. With the diagnostic is the most important moment is the computer tomography to notice size, location, and density. And two of the important moments from all of the patients, we take urine culture to make a less intraoperative or post-operative complications like a fever, infections, and any kind of complications. Ultrasonography takes the most important roles in the treatment because in the diagnostic we can see the hydronephrosis if we choose the mini PNL or another treatment, and when we make a punction, it takes the modern role to make a less X-ray radiation, like advises our colleagues from Kyrgyzstan and Azimjan Nazarjanovic. Was first important way to make a punction takes ultrasonography, and second with fluoroscopic guidance. We are done it with 16 Sharia mini nephroscope with Dornier Gemini holmium laser, takes 600 microns. Now it's a video. Oh, it's a video, but it cannot show it. Okay, it's not a modern.
Some support from the technicians to play the video, please. And
maybe
the time
at the
is
end
not
you
running.
can show it.
Can you play the video? Technical team? I just need a confirmation, yes or no.
Maybe at the end we can show
Okay,
it.
move.
The procedure were completed with placement of arrangement number 4.8 stent catheter in 43 times and nephrostomy to 40 Sharia in 6 patients. We are practiced tubeless and totally tubeless mini PNL, like as following according guidelines of EAU and our colleagues from other countries. Results. In 98%, the patients who underwent mini percutaneous nephrolithripsy, the kidney stones were completely fragmented and removed. Patients with small residual fragments up to more than 0.3 millimeters continued medical treatment with lithokinetic medication, with pH control of alka-acidotic pH of urine, with something like Blemerin and other medications. The duration of mini percutaneous nephrolithripsy takes between 30 and 120 minutes. The average 58 minutes. The overall incidence of intraoperative complications was 175% and postoperative is 267%. No bleeding occurred during or after operations in patients who underwent mini percutaneous nephrolithripsy just because of the selection and prepare of patients. Other complications such as persistent inflammation of the urinary tract were observed in 3 patients. But as we know about the urine culture, with correction, antibacterial therapy after operation, we prescribed and the condition successfully treated that situation. The average length of hospital stay ranged between 3-4 days after operation. We removed nephrostomy tube after 1 or 2 days after mini percutaneous nephrolithotripsy, and in good cases, we discharged the patients after 3-4 days in the middle. Conclusion, in our clinic, the minimally invasive methods of mini percutaneous nephrolithotripsy is considered one of the main high effective and safe treatment methods with patients with kidney stones measuring 1 or 2.5 centimeters. The main advantage of this method is a low frequency of complications and a high level of kinetic methods and less blood losing. Thank you for the attention, ladies, dear colleagues, and ladies and gentlemen, dear professors. Very proud to see you.
Good, thank you very much. We will take 2 questions, one from the audience. Yes, who would like to ask our young, brave colleague here a question?
Есть вопрос?
I know someone who would love to ask a question. Emre, please go ahead. And then I would still ask the jury to think of one question from your side, please.
Well, I think that this session, by the way, is an excellent session to give the young colleagues the podium. And having said that, I'm a big fan of mini PCNL. And do you think there is a limit for mini PCNL, or like Sven Lame says, is sky the limit for mini PCNL? Can you treat all stones with mini PCNL? What is your limit?
Our limit were, we prepared only 89 time patients. Yes, it's a very important question. But the choices between extracorporeal lithotripsy and mini PNL and regular PNL is to make less complications. But of course we have limits, because the most important moment in mini percutaneous nephrolithotripsy, in our experience, is to make it punction. And if we have no good punction way in the downsides of calyx,
let me make it easier
very
for
hard.
you. Okay, I don't want to stress you out. So the thing is, for me, even a large staghorn stone, I would go with mini perc. I don't switch to standard percutaneous surgery. I do multiple punctures, I do combined surgery, and for me, I think there's no limit to mini PCNL. But in your clinical practice, are there patients with staghorn, large complicated stones, where you say, well, let's go for standard cases, let's go for open surgery, anything like that? You may say no, or if there's a limit like this, you can just say that.
It's complicated because stones in our situation were between 1 and 2.5 centimeters, and they were positioned, they were very comfortable to make a lithotripsy.
Okay.
Only for this.
Question from the jury, please.
Microphone, please.
Nice presentation. I would like to know, why did the patient stay 3 to 4 days after surgery in the hospital? Because in 43 of those 49 patients, you just put in a double stent. And so you must have been very sure that this was a good procedure. Why did they spend so many days in the hospital?
We prepared the patients before operation, and Then, after the operation, we removed the nephrostomy tube after 1 or 2 days. With
in those where you had no nephrostomy, in 46 patients or 43 patients, you had no nephrostomy tube. You could have sent them home the next day.
Yes. We have, it's a middle, but we had sometimes we make, we keep the patients in the clinic more than 3-4 days, but
Yes.
it's average 3-4 days it takes.
Okay. So it's an average value.
Okay. Average.
Good. Thank you very much again. Congratulations for your courage.
Thank you so much.
So, as planned, we are going to move now to an online lecture, and we are again very happy to have Professor Evangelos Liatsikos from Patras, Greece, who a surgeon, an exceptional urologist with an impressive energy and experience. Evangelos, I'm not sure if you can hear us.
I can hear you. I cannot hear you very loud, but yes, I can hear you.
Perfect. So Professor Liatsikos is, on top of his incredible clinical activity, he's also running the European School of Urology. So Evangelos, thank you for joining us. Please start your presentation. Thank you.
So let me share. Thank you very much, Lorian, first of all.
We can see the presentation.
Is it visible?
Yes, it's good.
Excellent. So the presentation is the standards of the training in endourology. So in general, I would like to tell you that the school has focused a lot on the topic of standardization of education, of surgical education. There's a lot of work towards that direction, and you all well know, most of you are involved in the different teams that are working on this curriculum for the for the excellence, and clearly we want to create global standards and we want to implement it all around the world. So we want to create products that are going to be decentralized everywhere, and that everywhere people can work and use our products. The basic concept is that we have a stepwise system with a step 1, basic, intermediate, advanced, and then going into fellowship.
Evangelos, sorry to interrupt you for a second. We may not see, we only see the first slide. Have you moved? Okay, that's good, perfect.
Do you see it now?
Yeah, I can see the CISA urology slide, yes.
Only the CISA?
Yeah.
Only the CISA, nothing else.
Okay, EAU surgical training standards. Is it the one that you...
Okay, am I moving this now, or is it moved by by your guys? So it's fine. EAU surgical training, as I said, the EAU is planning to create a whole curriculum. Next slide, please. Of training that is going to be implemented and decentralized all around the globe. Next slide. So the concept is to have steps. The bootcamp, you all know, we do it at a very beginner's level, into residency, and then we have basic step, intermediate step, and advanced, and then fellowship for every surgical technique in urology. Next slide. So like a pyramid concept, basic and complex, and then you end up doing the entire procedure. Next slide. And again, this is for all the procedures. This is something developing now for the last 3 or 4 years. There are 10, 11 working groups working on this, and really, it is really booming. Next slide. One of those groups is endourology. So endourology, next slide, please. Next, and as you will see, the protocols that we have right now. Next slide. Sorry for this, I cannot move it from my computer for some reason. There are different steps. So there's endoscopic stone treatment, step 1, step 2, then transurethral, step 1, then you go to the prostate, then you go to laparoscopy also. So there is a huge quantity of these training concepts and training models that are spread, validated, published, and we are using them right now. They are very highly requested all around the globe. Next slide, please. If we go into the analysis of this, the STS1, I repeat, most of you are very familiar to these concepts because you are part of these working groups. So the first step is the basic stuff, basics in endoscopy, and then we go to STS2, which is the flexible ureteroscopy, and there is a development now on PCNL, which is very interesting. PCNL is really, the models that we are creating are very nice. And the team on that is really doing a great job. Next slide. And we have a very meticulous, way of doing it. And there is tasks with timings and steps and tests that people do them. They pass or fail, and they get the accreditation of this basic step in order to move to the next step. These are all really interesting concepts. Next slide. Task 2, for example, step 2, as you will see here, again, ureteral stone fragmentation, kidney stone fragmentation, stent placement. Everything is standardized. Standardization is the key of success in all these concepts. Next. Then we go into the lower tract endoscopy. So up to now, we have the transurethral treatment step 1, which is already validated, and the team is working on bladder, prostate, and enucleation. The models are fantastic. Enucleation model, most of you know it. You have seen it at the EUREP. It is really, really very good, and it's under development. And it's something we're using now in the best of EUREPs around the globe, also in different locations, and it's really of high success. Next, please. Just to analyze again, same concept, same idea. Every group has to set up the same concept of modules and training, like task 1, task 2, task 3, task 4. This is step 1, and it seems sometimes that step 1, task 1 is easy, for example, but we are referring to everyone. We are referring to the global urologists. We are referring to the African urologists. We are referring to any urologist. So we need to take care of all their knowledge and all their expertise, all the spectrum of expertise that we can. This is step 2. Next slide, please. Next, please. So step 2 again, we have cystoscopy, medium lobe resection. This is the basic part is the same, but then we go into the medial lobe resection, lateral lobe resection, and exit strategy. So all these are very nicely described. Next slide. And next slide, please. And as you see also, it's really nice resection concepts, tumor resection for bladder tumors. Next slide, please. You know these. And I don't want to really go into deep detail into it. Laparoscopy. Laparoscopy is endourology also. So there's been a huge success there. We all know that the whole thing started with the EBLUS, and that has become viral across the world. And one of the people that has really contributed into this is our big friend that is not with us anymore, Ali Gozan. We always need to remember him. He helped a lot into the expansion around the globe of this concept. And now we have the intermediate training, and in development, the anastomosis and pyeloplasty, vesicoureteral anastomosis and pyeloplasty. Next, please. And this is really very interesting. People are taking this exam all around the globe. Wherever I go, I see the EBLUS exam and the EBLUS concept and our EBLUS patented platforms being there. Next, please. Step 2 is very interesting because we really have created the more advanced kind of concept, and not only created it, but as you will see, please play the video. Next slide.
Major vessel injury.
Please go to the video, to the slide with the video, please.
Major vessel injury. Step by step. For this exercise you will need 2 needle drivers, a braided suture 3-0 with curved needle, and a 4-0 or 5-0 proline suture. First perform a figure 8 stitch using a suture with freehand knot tying. Tie a single knot with 1 double throw and 2 single throws.
Next one, please.
Then use 2 or 3 throws of continuous suturing and knot the end to the beginning of the suture.
Next one, please. So just to show you, I mean, this is a YouTube video. So we are creating now for every task YouTube videos that people can go, audio visuals that they can go in, labeled school and everything, and they can go in and learn how to do it. And this vessel injury concept is very nice, a very nice video. You can go in and look it for yourselves. And not only for vessel injury, but also for other aspects. Like the step 2 here is rhinography. This is a partial nephrectomy. Next one, please.
Partial nephrectomy. Step by step.
Next one. So the robotics have well established a long time ago the CCERUs. So they have a very, very nice and meticulous training plan, starting from basics to intermediate and to advanced, ending in ORC. And ORC, as you probably well know, is the place for the advanced robotic training, which EAU is highly involved with. And seeing that, next slide, please. Everything is proficiency-based driven and evaluated afterwards. So it is not based on a robotic platform. It is based on the robotic concept. So it's very interesting. And for everyone that is going into robotics, I think in the future it's probably going to be mandatory. Somehow we're going to combine the accreditation with the exams so that everyone has a certification that he's proficient in doing something. Right now, we're in the very beginning of this concept, but the EAU is highly discussing about certification and validity of these certificates in the different aspects of the training. So having said this, and I'm sorry I'm not there with you, but you know, the school has really, and the EAU has really structured training with the help of every one of the sections, of the working groups, in a way that we at the end of the day can establish a very high profile training standardized method that is going to be accredited around the world, and we can actually have our protocols everywhere spread around the globe. Thank you very much.
Thank you very much, Evangelos. The European School of Urology has done an amazing job within the last years since you took over, and there's a lot of work for us.
Please talk a little bit louder because I can't hear you well, Lorian.
I was thanking you, and I was saying that the European School of Urology has done an amazing work over the last 2-3 years, and we have lots of work to do in the future. And I think you agree with me that if we have young urologists from this part of the world who would like to join us and be involved in these activities, we would be more than happy to have them with us.
This is a key point. Unfortunately, you know, this is one of the most interesting parts that you are raising here, because we are looking for young, crazy people that want to work and dedicate their time in education and what we are doing, because what we are doing is not easy, and you really need to be motivated for it. So yes, we are looking for young, motivated people from anywhere. So feel free to contact me or feel free to contact any one of our team, and we will be happy to have you with us.
Good. Thank you very much again, Evangelos. We miss you here, but hopefully next year you will be with us. Thanks again.
Thank you very much, Lorian. Thanks a lot.
So we will move to again to young urology competition. The next lecture is Samandar Timirov, a representative from Tajikistan, Dushanbe. The topic is the long-term results of M-block 2RBT for the high-risk NMIBC.
Dear ladies and gentlemen, I'm glad to see all of you right now here. My name is Timur Samandar, and today I want to talk with you about long-term results after en-bloc resection of bladder tumor for high-risk non-muscle invasive bladder cancer. I know that everyone who's sitting here right now knows everything about bladder cancer, about its etiology, pathogenesis, and epidemiology. As you know, etiology and pathogenesis doesn't change year by year. They are always constantly. So what about currently epidemiology? Currently epidemiology looks like bladder cancer takes from 1 to 8% of all malignant neoplasms. Non-muscle invasive bladder cancer represents about 67% of all cases. In 2025, the incidence ratio was about 3%. The mortality rate was about 2%. 75% of all patients was patients in the age from 60 to 80 years old. The ratio between men and women was 4:1. Stages of bladder cancer using TNM classification. Non-muscle invasive bladder cancer starts from T in situ, TA, T1. Muscle invasive bladder cancer starts from T2, T3, T4. So what about metastatic? Metastatic is N1, M1. Group stratification of patients with non-muscle invasive bladder cancer. To the low group, we can include all the patients with primary solitary TAG1 tumors with the sizes less than 3 centimeters, no carcinoma in situ tumors. To the intermediate group, we can include all the tumors between the high-risk group and low-risk group. To the high-risk group, we can include all the patients with the tumor sizes more than 3 centimeters, to the multiply tumors with the recurrence tumors and T1, G3 tumors. Also, we can add to this group carcinoma in situ tumors. Most patients with metastatic bladder cancer progress from the early stages. Up to 35% of all non-muscle invasive bladder cancer have progressed to the muscle invasive bladder cancer. About 20 to 50% of muscle invasive bladder cancer have progressed to the metastatic diseases. And only 4% of all bladder cancer were initially diagnosed in the metastatic stages. From here appears one question: why? Less of diagnostics, lack of treatment, or maybe wrong way of method of resection? So which method of 2RBT do we know? Vertical resection, horizontal resection, sub-base resection. The most valuable problem which appears after 2RBT is recurrence. So why does it appear? Here is some causes of recurrence of non-muscle invasive bladder cancer. Firstly, progressive de novo tumor, undetected tumor, unidentified firstly carcinoma in situ, incomplete resection, or implantation. How can we prevent the recurrence? Firstly, to use more modern and precise method of diagnostic of all growth zones. To these methods includes modern telescopes and cameras, PDD technology, NBI technology, zoom, IGB, spike endoscopy. There are a lot of methods which we can use. Following, we can say that using of more quality method of diagnostics increases the completeness of resection and our radicality. So what do we know about en-bloc resection? By me, the main goal of the en-bloc resection is to transfer translateral resection from diagnostic and therapeutical category to the radical treatment category. Key points. ERBT is developing alternative to conventional TURBT. And block resection also provides us higher quality specimens which enhance the information value of pathomorphological examination. Also, we should remember one thing, that the using of in-block resection depends on tumor sizes and its localization. On this video, I have demonstrated one of my cases where I have used in-block resection to the patient with solitary tumor on the right bladder wall. I have gone 1 centimeter out from the tumor and trying to go under the submucosous layer and work in this layer. At the end of resection, in my biopsy material will contain detrusor, which helps us to take more precise pathomorphological conclusion. I'm using bipolar loop and going under the submucosous layer and work in this layer. On this slide, I want to tell you about the advantages of ERBT, which I have felt on myself. Firstly, no contraindications. Depends on sites, number, localization of tumors, orpheus involvement, and something etc. High ablasticity and radicality, complete hemostasis control, use of low flow perfusion. Like at the last video, I've used low flow perfusion. The detrusor wasn't stretched, and the intravesical pressure was also low. Minimal risk of complication, no indication of ETN, minor thermal damage to the detrusor, and also high quality material. Material and methods. We have selected 2 similar groups of patients. To the first group, we have used ERBT. To the second group, we have used conventional TURBT. As you can see, all the numbers are the same, and most of our patients was in high-risk group. 124 patients in high group in first group, and 123 patients in second group. The most valuable index of our treatment's efficiency is recurrence-free survival. In this table, we have studied recurrence-free survival of our 2 groups of patients, 1-year recurrence-free survival, 3-year recurrence-free survival, and 5-year recurrence-free survival. Numbers show us that the ERBT is more efficient than conventional ERBT in recurrence-free survival. And also 5 years recurrence-free survival, almost twice higher than recurrence-free survival after conventional TURBT. 62% against 35%, it's much more twice higher. What about progression-free survival? From this table, we can see that the progression-free survival was also much more higher in ERBT patients group for intermediate and high-risk non-muscle invasive bladder cancer. Time to progression. Time to progression after conventional TURBT was about 23 months. In the group of after in-block resection, it was about 53 months. And also, this number shows us the efficiency and advantage of in-block resection. In conclusion, I want to say that the results of our study demonstrate a statistically significant positive effect of the ERBT method on 5-year recurrence-free survival and on progression-free survival to the patients with primary non-muscle invasive bladder cancer. The achieved results can allow us to recommend to everybody use the in-block resection in patients with primary non-muscle invasive bladder cancer with high-risk group. Thank you for your attention.
Thank you, Samandar, for very nice presentation. Any questions from the audience? Emre, please.
Thank you very much. Thank you very much for this presentation. I feel like I'm talking all the time, asking questions, but anyways. So I am a fan of unblock resection of bladder tumors, and I think it should be encouraged, and whenever possible, it should be resected unblock. But just a small, have you ever seen a complication of extravasation of intravesical chemotherapy? Have you ever had this kind of case?
I understand you.
So, just a moment. So, I think the early intravesical chemo is very important to prevent recurrences.
Yes, of course.
Of course. This is already established. But this practice can be a little bit dangerous with unblock resection of bladder tumors. So that is why when I do unblock resection, I try not to give intravesical chemo. So what's your perspective on this?
As I said before, in block resection had its own conditions. Just maybe when the size of tumor is so high, so big, or maybe when the involving of tumor is much more deeper, the using of ERBT it's little bit complicated, I think. That's why we can use the conventional TURBT. There is no problem. Maybe you can speak much more louder.
That's not my question. After unblock resection, have you ever given intravesical chemotherapy in the early postoperative period?
Of course, of course. After 2 till 6 hours after our in-block resection, we just making infusion, intravesical infusion of doxorubicin in 50 milligrams with 50 milliliters of natrium chlorium, and with the exposition in 1 hour. That's the main part, because if we don't give this, the recurrence will be obviously.
Any question from the?
Nice series, because it's your own material. I was surprised to see that you said there are no contraindications or no limitations for unblock resection, because sometimes you have multiple tumors, small sessile tumors. Sometimes you have very big tumors where it is difficult to find the right way. So it is difficult to imagine that there is no contraindication. And therefore, my second question is the fact, are these two groups, which were similar in number, really prospective, randomized, blind, randomized cases, or were they selected? Because how do you explain the big difference in recurrence rate, progression rate, and so on? Randomly selected, blind, randomly selected, two series. The 2 case series, were they randomly blind selected cases? Or did you select the patients for one or the other procedure?
Sorry, Professor Alkin, a little bit complication with understanding you. Why in block? As I've said, only for this we made one study and divided patient to 2 groups and tried to put in this group such patients, the most similar patients. Yes, similar patients with similar diagnoses. So they're just, for example, similar sizes of tumors, similar features of tumors. And that's why this is our little study. It cannot be so much retrospective or randomized study.
It was retrospective. It is a retrospective study.
Yes.
Is it retrospective?
Yes.
Yes.
It's retrospective. investigation. That's why it just was my experience and just some conclusion which I have made for myself and for recognize of in-block idea. Why does it in-block is so much popular nowadays?
I have also one question. So how did you determine the risk category of the patients? And the second question, tell us a little bit about your follow-up strategy for these patients after en-bloc TURBT.
All of these patients were surgered in oncological center, and we have our database of the patients, and after the surgery, our patient doesn't go anywhere. They're always under our control. That's why they coming to us after the control to the...
No. Как вы определяли риск категории пациентов? Как вы определяли, что это пациент группы высокого риска?
Используя классификацию TNM и градацию по G1, G2, G3.
Как вы определяли, каким методом вы определяли именно риск категории как бы пациентов? Как вы установили диагноз, что это пациент как бы из группы высокого риска?
Мы учитывали размер опухоли, мы учитывали их количество, мы учитывали их локализацию. То есть это основные методы. И также предварительную градацию.
Okay, thank you. Thank you. So our next competitor is from Uzbekistan, Jahangir Shadmanov, and the topic is RIRS is the solution to all problems?
Yes, sir. So, here, more exciting from there. So, I'm Shadmanov Jahangir. I'm head of urology department of National Medical Center. So my title is RIRS the solution to all problems. So RIRS has changed our daily practice, but have we started asking too much of it? And RIRS is an excellent option in selecting patients, but not a universal solution. I mean, it's not a goat. We all know EAU and AUA international guidelines for kidney stones, lower pole stones excluded. You all know about it. I will skip it. This is our device for pressure control suction system. It's an INT Medical Chinese device. My slides. It was a video. Okay. The best candidates for RIRS, it's from small to medium kidney stones and resistant to other treatments. For instance, stones up to 2 centimeters, but we know that using flexible URS, we can perform and above 2 centimeters also. And in cases where PSNL and shockwave lithotripsy are not options. And if you have a failed shockwave lithotripsy, and ideal renal pelvis, and maybe upper or middle calyx stones. And patients who are poor candidates for more invasive surgery. Elderly patients, and patients with bleeding disorders, or maybe patients on anticoagulated therapy, and those who should avoid percutaneous surgery, and some religious issue, maybe like Yagos, they not allow to the some blood components. And the next positive side of RIRS is the anatomical situation. Abnormal kidneys, for example, horseshoe kidney or transplanted kidney, narrow or difficult access where ESOL might fail. And obesity. We know that shockwave lithotripsy and PSNL maybe less effective in this situation, and RRS will be a nice option. And I found this trial from our Russian colleagues, safety and efficiency of a retrograde intrarenal surgery without X-ray guidance. They, after first session, stone-free rate was 92%. And in these cases, we also may work with X-ray negative stones also. In some cases, maybe PSNL with multiple calyx stones may be some problematic if the stone will be X-ray negative. And who need stone-free rate up to 1%, 100% after PSNL? In this research, it was a shockwave lithotripsy vs retrograde intrarenal surgery with residual stone fragments after percutaneous surgery. And RRS has better stone-free rate, higher minor complication, and lower major complications than as well for the treatment of residual stone fragments after standard PCNL. FANS is the game changer. It was a very attractive trial, comparison of section technique and non-section technique in RRS. It was a systematic review. And RRS significantly improves clinical outcomes by reducing operative time, hospitalization duration, and enhancing stone-free rates, and lowering post-operative complications. In my practice also, after purchasing FANS technology, my operative time reduced 3 times. And in these situations, when we have a bilateral kidney stones, up to 2 centimeters, the best option may be bilateral RRS. Here was a very nice research, the utility of FANS in patients undergoing same session flexible ureteroscopy for bilateral renal calculi. Conclusion was that this is the first multi-center study where the use of FANS in same-fitting bilateral RRS can achieve bilateral zero residual fragments with low complications, zero sepsis, and low re-intervention rates. And maybe some problems with RRS when you have an extremely acute lower pole angle. In this image, we can see the medial calyx of the lower pole is more than 180 degrees. In this situation, difficult intrarenal access despite the flexible scope. And some problems with the Stackhorn calculi and stone more than 3 centimeters. And next, some problems maybe, we know it's a cost of scopes. We know that they are not reusable, but in some countries, we can reuse the single-use scopes. And due to the high cost of scopes, they may be reused, thereby increasing the risk of sepsis and high residual fragments. And here was a nice research. In 75%, they know the defect of the reusable scopes, but they use it. And interoperating scope changes was in 3.9%, and sepsis was in 1 and 3%, and fever in 13 and 7%. And some postoperative complications, the highest complication was the residual fragment rates, 31%. And next problem, maybe ureteral wall injury. Even we will perform pre-stenting, we will feed, give A blockers to the patients for 1 or 2 weeks before the surgery. Even we have a normal, not narrow ureter, we may injure our ureter. Here, images from the classification of Olivier Traxler and Alexander Thomas. It's a 5 grades. The the most complicated type is avulsion. So overall complication rate after URS is from 4 to 25%, and most complications are minor and not require intervention. Urosepsis is a severe complication with a risk up to 5%. Ureteral avulsion is a rare but severe complication with a risk of 0.04 and 0.9%. With a ureter stricture rare after URS found to between the 3 and 4.9%. And we all here endourologists, and after RRS we insert the stents, ureteral stents. And here was a consensus which they recommend placement of ureteral stents in most patients and removal within 1-2 weeks if no injuries. And using A blockers for 3 or 4 weeks reduce to stent-related symptoms and increase tolerability. For reduced stent-related symptoms, you can use A blockers, and we have some special pigtail suture stents for reducing urinary symptoms, intensity of pain, and deterioration in general health. They will reduce all these stent-related symptoms compared to the conventional stents. Here in the image we can see that distal part of the stent removed instead of they put the mesh for reducing the stent-related symptoms, because we know the most cause of these symptoms are distal part of the stents. And some clinical case. 3 centimeter Stackhorn stone, patient on anticoagulated therapy. Which surgery will be more usable for this patient? We have PSNL, RRS, and shockwave lithotripsy. We know that RRS will be best option if it will be up to 2 centimeters. But here, patient on an anticoagulated therapy. That's why here I think the best option will be RRS. And second clinical case, and 1 and 5 centimeters impacted upper ureter stone. In this case, we have a PSNL, percutaneous antegrated ureteral lithotripsy, RRS, and as well. And in this case, will be nice option is percutaneous antegrated ureteral lithotripsy, because impacted stones, they may how to say, increase the duration of operation and cause more complications, maybe intra and post-operative. So RRS,
30 seconds.
So RRS works very well here. That does mean it should be our first answer in every case. Thank you. I had a videos, but I don't know here. It's lost. Thank you.
Thank you, Jahangir. Questions from the audience? We have a question from the
Thank you for your nice presentation. My question is, as we know, the most complication happening during the IRS happened during the installing access sheet. Even we are presenting these patients. And do you routinely do ureteroscopy before installing access sheet with semi-rigid for preventing this type of, for assessment the lumen of enlarging ureter?
Thank you for the question. In my practice, every time I perform with the semi-rigid ureteroscope, I perform ureteroscopy, and after put the guide wire, after that put the sheath.
Thank you.
Thank you.
Thank you for this nice presentation. I would like to ask you, you have mentioned that the fans sheet has reduced your operation time 3 times.
Yes.
Is this a subjective view? Because it's a really important and a significant amount of time. Instead of 1 hour, for example, has it decreased to 20 minutes?
Yeah. Okay, thank you for your question. Yeah, it's maybe subjective, but our time shows that it was reduced to 3 times our operating time. We didn't use basket, so all our fragments will remove with the fan system, and it will reduce our operating time. Thank you.
Just a very short questions. For you, in 2026, what is the main limiting factor to perform flexible ureteroscopy?
Excuse me, I don't understand.
What is the main limiting factor not to perform
for RRS?
flexi, yes, and to go for another options, like PCNL, for example? New personal decision.
For me, as a surgeon, it's maybe only infected stones and huge stones. But for patient, maybe it's cost sides for the RRS.
Good.
Thank you.
Thank you very much. Well done. Congratulations. And at this stage, I think we owe you lots of applause from our side, actually. Thank you very much to everyone who stayed in the room until the end of the session today. We've had an amazing day, live surgery, excellent lectures, and I think we finished with a very nice example that our young colleagues can deliver very good surgery. Enjoy the evening. See you tomorrow for another good day of Congress. Thank you very much to everyone.
Ladies and gentlemen, distinguished speakers, and dear participants, thank you for being part of the first day of the Central Asian Endourology Congress 2026. We sincerely thank all speakers, moderators, and guests for their contribution. We look forward to welcoming you tomorrow for the second day of the Congress. Have a pleasant evening and see you tomorrow.